ٹھیک ہے اب بولیں.
ہیلو.
اب میں ہی کال پہ ہوں نا, میری آواز آ رہی ہے؟ میں کال پہ ہوں. کیا چیز؟ اچھا علی حسن یار, یہ دیکھو یہ دونوں ان میں کیوں نہیں آ رہے؟ ہاں جی, اب آواز آ رہی ہے میری؟
ذرا چیک کریے گا زوم ٹیسٹنگ دے دیجیے.
ہیلو
ہیلو, کیسے آواز آ رہی ہے آپ کو؟
آواز آ رہی ہے؟
کیسا آواز آ رہی ہے آپ کو؟ ان کو آواز نہیں جا رہی.
السلام علیکم. ہاں جی, نہیں آپ لوگوں کی آ رہی ہے نا, میری آ رہی ہے؟ نہیں, اور آپ لوگوں کی بھی نہیں آ رہی. نہیں جی,
ہماری آواز آپ کے پاس جا رہی ہے.
اب آئی ہے لیکن بڑی سلو آئی ہے.
وہ ایسا ہی بول رہا ہوں.
اچھا چلو, اور ہماری میری آواز, ہاں جی میں بول رہا ہوں, آ رہی؟
ہماری وائس جا رہی ہے.
نہیں, اب آپ کی آواز بھی نہیں آ رہی.
ٹیسٹنگ
آپ کی آواز بھی نہیں آ رہی.
ساؤنڈ چیک کریں. اوکے, تھینک یو.
سر میں بول رہا ہوں لیکن آپ لوگوں کی آواز بھی نہیں آ رہی.
آ رہی ہے نا؟
جی جی جی, ہیلو ہیلو ہیلو,
آ رہی ہے نا ابھی؟
ایسا بات کریں ذرا.
جی ہیلو، اب آواز آ رہی ہے؟
بھائی صاحب
جی جی میں
ذرا
بول
بات کیجیے گا.
جی میں بول رہا ہوں.
بھائی صاحب میری آواز آ رہی ہے آپ کو؟
سر آپ کی آ رہی ہے، میری نہیں آ رہی. یہ گن لو نا. ٹھیک ہے. سر آپ کی آواز آ رہی ہے، میری آپ کو نہیں آ رہی. ابھی تو آپ لوگوں کی بھی نہیں آ رہی، ابھی تو آپ کے لوگوں کی بھی نہیں آ رہی. اس وقت اب نہ آواز آ رہی ہے نہ جا رہی ہے. کل ہر چیز فنی کرتی ہے. پتہ نہیں کیا ہوا. نہیں ہمارے IT کا بھی ایشو نہیں ہو رہا. ایک چیز آپ صبح ابھی مائک میں سے ایکو آ رہی ہے، کل سارا دن مائک چلتا ہے، آج مائک میں سے ایکو آ رہی ہے.
سر وہ ساتھ کسی کنسلٹنٹ کو دیکھنا تھا یا کسی جنہوں نے ریسیو کرنا ہے جسٹ آنے والے ہیں تو اوبیسلی وہ ساری مینجمنٹ نیچے کرتی ہے ان کا رابطہ. ایم ڈی صاحب بھی نیچے ہیں اور ایچ ڈی صاحب بھی نیچے ہیں. جی صاحب جی جی گیٹ جی جو لوگ آپ کے ڈپارٹمنٹ میں آپ کے سیکشن میں افورڈ
جی سر. جی اوکے.
مجھے نا لنچ باکسز لے کے آنے ہیں کائنڈلی کوئی ایک ایڈریس جو ہے وہ ادھر پرٹیکولر سائٹ پہ اگر مجھے کلاس گاڑی میں آتے ہیں
ایچ ڈی صاحب کی کال آئی ہے کہ فرنٹ 3 روز خالی رکھیں. کہاں بٹھا گیا ہے، کس رو میں؟ یہ جی ایم صاحب کو کال کر کے انہیں بتاؤ، کیونکہ سر کہتے ہیں جی ایم سے رابطہ کرنا. جی ایم صاحب کو کال کر کے بتاؤ کہ سر یہ اس طرح اس بات ہے. جی ڈاکٹر صاحبہ. ہیلو. نہیں علی حسن. جی ہیلو. میں آئی ٹی سے پتا کرتا ہوں کہ کیا چلا سکتے ہیں، میں کرتا ہوں. نہیں یار علی حسن نہیں وہ تو کوئی ارسلان لے جو چاہے. ارے بلالی آئی ٹی والوں سے پتا کرو وہ جو اسکرین ایک تو لائیو اسکرین ہے جو دوسری اسکرین ہے اس کے اوپر کوئی بھی پی کے ایل آئی کی کوئی ڈاکیومنٹری چلاتے ہیں ڈاکٹر ہمارا کہ ابھی آپ مجھے نظر آ رہے ہیں لیکن ان سے زوم والا مسئلہ نہیں حل ہوا ابھی تک. اور نہیں بھائی یہ تو کیمرہ ہے جو پینلسٹ کا ہے جس کے اوپر آپ کی وہ چلتی ہے. اور نہیں یار تم پینل والے کیمرے میں ہو بھائی سن لو نا جس پہ وہ چلنی ہے پریزنٹیشن چلنی ہے بڑی اسکرین پر ایک لائیو اسکرین ہے ایک بڑی اسکرین ہے اس بڑی اسکرین پر ڈاکیومنٹری کوئی چلوا دو. تو ابھی اسے ختم کر دو نا یہ تو ابھی ان سے نہیں ہوا ہے ہینڈل ہو رہا. بھائی جی وہ کیا مسئلہ ہو گیا ہے. نہیں تو ابھی یہ جو شاید ڈاکٹر صاحبہ نے وہ کروائی ہے اس کی وجہ سے تو نہیں کوئی مسئلہ. یار اب تو ٹائم بھی نہیں رہ گیا یار.
بولو اوپن
हाँ जी हेलो।
माइक चेक।
हाँ जी आपकी आवाज आ रही है, मेरी माइक चेक की आवाज आई है। और यार तुम लोगों की आवाज, माइक बोलो ना माइक पे कोई।
माइक चेक।
आप लोगों की आ रही है ना, मेरी नहीं आ रही। हाँ तो वो मेरे। हाँ जी हेलो हेलो। हाँ जी हेलो 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 हेलो।
Ladies and gentlemen, please take your seats. We are going to start the event very soon in a few minutes, as we are just waiting for our chief guest who reportedly have arrived at the PKLI. Ladies and gentlemen, our chief guest, Ahsan Iqbal, Minister for Planning and Development, has arrived. Please welcome. Bismillahir Rahmanir Rahim. Ladies and gentlemen, let's start the event with the recitation of Holy Quran. And I would like to invite Qari Hafizullah Sahab.
السلام عليكم ورحمة الله وبركاته. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إن هذا القرآن يهدي للتي هي أقوم ويبشر المؤمنين الذين يعملون الصالحات أن لهم أجرا كبيرا وأن الذين لا يؤمنون بالآخرة أعتدنا لهم عذابا أليما صدق الله العظيم.
Jazakallah. Honorable Chief Guest, Ahsan Iqbal Sahib, Federal Minister for Planning, Development and Special Initiative, Chairman, Board of Governors, Honorable Dean, Director General Health, esteemed professionals, international speakers, guests, esteemed consultants, ladies and gentlemen, I sincerely welcome all of you on behalf of PKLI today. It's a great honor for us to see you here for a great noble cause. And I feel very important to emphasize that PKLI, as its name stands, is a national institution which has a very clear strategic vision for not only provision of specialist healthcare and organ transplantation, but one of the core concepts of creating this institution was to fight against preventable and curable diseases. That was the clarity of the vision of this institution and the leadership, and all of the support we received from the ministry, for which we are thankful to Ahsan Iqbal Sahab, federal and provincial governments, to collaborate, integrate with all of the stakeholders and to bring them on a unified strategy so we can effectively deal the challenges of viral hepatitis to eliminate it successfully as desired by the international community. So ladies and gentlemen, We have a very exciting programs for the day today. We have many invited esteemed speakers who will be sharing their experience. There is a plenty of opportunity to learn about different strategies, different measures which we can successfully implement in our national program to eliminate this deadly disease from the surface of the Pakistan. And indeed, we will remain in international collaboration, and we are committed to work hand in hand with WHO and the pharmaceutical industry. Once again, I'm thankful for your very kind attendance. And now it would be my extreme pleasure to invite the Chairman Board of Governors, Professor Dr. Saeed Akhtar, to please come up on the stage to share his wisdom and vision, how this strategy is going to reshape the future of healthcare in Pakistan. Please welcome Professor Dr. Saeed Akhtar.
Thank you so much. Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Qul huwallahu ahad, Allahus samad, lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahul azim. Honorable Hasan Iqbal Sahab, distinguished guests, ladies and gentlemen, welcome to PKLI. People who have not been to PKLI, I would definitely want my team to arrange a tour for them to visit PKLI and understand that we are trying to build a center of excellence, not only in the clinical care, but in other aspects as well. So why this event? What is the purpose of this event? So I'm going to actually lay the stage, and the whole idea was that we will have this event in the morning, and I had requested Hasan Iqbal Sahab to come at the tail end of it, if that was possible, and then at the end of the event, we will just sit together, create very clear roadmap, and then present to PM, because the original PM function was scheduled today. But unfortunately, things did not work out that way, which is perfectly all right. And then Hasan Iqbal Sahab had to catch a flight to Karachi. And I'm very grateful to you, sir, for your presence here, despite your extremely, I see your messages at 1 in the morning. So I understand how busy things are for you right now. So this actually shows your commitment and your vision. And without that, we could have not achieved what we are starting today. In my judgment of things, elimination of hepatitis is not only a dream, but I think if I can think of one doable thing, I have a lot of desire that we can eliminate diabetes, we can eliminate hypertension, we can cut down the renal failures, we can cut down the liver failures. But if we have one single doable, surgical, strikeable target, it is hepatitis C. It is absolutely doable. I mean, it's not anything rocket science. And then Faisal and all my hepatology colleagues will tell you how much misery they see from people who are suffering from hepatology. So next slide, please. So basically, I'm here to lay down the table. And what I'm requesting today, a couple of things I want to make a request. This is not a PKLI initiative. This is a national initiative. PKLI is just a collaborative into the national initiative. So when we leave this room today, we leave with the idea that it's a national mission. It's a national project that we have to accomplish it as a nation. This is not Punjab. This is not Sindh. This is not Balochistan. This is Pakistan. This is the humans of Pakistan that we are talking about. And this one single day can actually lay down the map, followed by multiple meetings for further tactical details. But if we leave this room today, by the end of the room, we are all on one page. And I have the best experts from the world sitting in this room who are here to guide us. People like Imam Waqid, and I thank you for coming here, coming from Egypt, who has actually, they have eliminated hepatitis from Egypt. So if they can do it, we certainly can do it, because, we are very comparable countries actually. So this is the goal, and it's a very, very ambitious goal. It will take some time. So 90% reduction, new cases, 90% infected patients can be diagnosed, And then out of that, 80% to be treated and 65% reduction in mortality. ये थोड़ा सा screen को stabilize करोगे. So the most important thing is what we have learned in last 10 years. And there's a tremendous amount of data. I'm not a hepatologist, but I went through a lot of data as an epidemiologist and there's a tremendous amount of data. And I'm glad we are doing it in 2023 because we have much more information now than we ever had before. So we have a lot of resources, intellectual, physical, scientific, diagnostic, treatment, et cetera, et cetera. And then we learned a lot of things from COVID also. So COVID actually gave us a roadmap of how these epidemics take place and what we need to do. And so I have a couple of questions, and I'm leaving these questions. These are the questions that I have as an epidemiologist. And I'm leaving these questions for you. I bet there's no right or wrong answer, but I think this is what we need to discuss. So we are planning that we're going to target people who are above 18 years of age because of the restraint of money. And I ask myself a question. We are making a tremendous amount of physical effort, going door to door or whatever the strategy may be. And are we going to do that again? Is it worth saving money now, or should we invest upfront money and just screen everybody? So do we also look for Hep B simultaneously because it's all the same disease or same spectrum of the disease, the same mode of spread of the disease, or we should just leave it to Hep C? Again, you know, I know that there's a lot of money involved, but these are just the questions I'm raising, especially for ethnic violence. So how do we get provinces on board for matching funds? And that's also a very important question. And sir, before you leave, I think to me, when I analyze a project with a SWOT analysis and I look at the risks of the project, I think for me, I think for you as a father figure of the nation dealing with the planning, it's extremely, from my understanding of things, it's extremely important that we take provinces on board, just like they are kids, and we just take them on board and facilitate them in any possible way that we can. And I think we will discuss about that as well. Because I think that's another weakness that I see that may jeopardize our mission. Can we and then I think one thing is very, very clear. If we are going to do a very sporadic kind of a work, then we are not going to do it. It has to be all out, single surgical strike simultaneously. And the way I think Pakistan has gone through a lot of terrorist activities, unfortunately. And in one way, we have really specialized how to survive these terrorism. And I think this is no different than combing out terrorists from the country. The hepatitis C is like a terrorist. We have to find wherever it is, and everybody has to hold hands together and just eliminate it, just like we have eliminated the terrorists. So it has to be all out, a very well-planned surgical strike. Without that, we're not going to head. And the disease reservoir is so big, so it keeps reinfecting. And there's a tons of data that I was looking at in 54 countries. They were treating on one hand, and on the other hand, the rate of reinfection was higher. So there's no point in doing very sporadic little treatment when the pool is so big that they keep infecting each other again and again. So we have to go with, again, all-out approach. So what's the cost-efficient way of making a diagnosis? I think this is a very sticky point. This is a very debatable point, and I have the best experts sitting here, and we are going to discuss that. Do we go with steps, antibodies followed by RNA? What is the best POC or point of care test for the antibodies? Do we do RNA as a PCR versus core antigen? What are the advantages, disadvantages? POC RNA detection, I think that's the new horizon that we are looking at. If we can just, with the one stick, we can diagnose it on the doorstep without ambiguity that is antibody positive. Now we're going to do the RNA and then treat the person. Because we have done, and Amara is going to share our data of PKLI with you. We lost a lot of patients between the diagnostics, actually. It doesn't work that way. So, and then a lot of very exciting new things are coming up, polymers, nanoparticles, but they all need, what's their sensitivity, what's their specificity, do they need WHO pre-qualification, etc. And then what will be our method of sampling? Do we do the venous puncture? We do finger stick? we do dry blood spot, et cetera, et cetera. And how can we minimize testing and how can we minimize punctures? Because that's another very big debate in the literature where you lose your patients and bring them to the end to the treatment. Most efficient way of how do we link the care to all this diagnostic armamentarium? How to reduce dropout rates and non-compliance? What are the best meds available? And thank God we are in 2023 that we really have best meds and we have really shortened the duration of the treatment. What's the cost efficient way of delivering that medication to the treatment? I mean, angels are not going to drop that medications. We have to devise something, somewhere, how we're going to do it. And do we need to do a follow-up SVR when we are looking at the entire country, or can we save some money over there? But, as a scientist, I still feel that we probably should do SVR, but again, it's up to you guys, hepatologists, to decide, not me. And how do we prevent reinfection? So similarly, we need to really augment all the prevent. Again, sir, as a federal minister and whoever the health officials are here from the province, this is not going to cut out unless we take a simultaneously approach of people who are spreading it. So if you need to bring a policy of auto-destructible syringes. I mean, we need to get rid of these reusable syringes, which are still infecting people day and night. We have to check on our barbers, our dentists, our hospitals, our government hospitals, our private hospitals. They are spreading infection left, right, and center. What have we done about that? So are we going to just leave that alone and just give some pills to somebody and expect that the epidemic is going to go away? It's not going to go away. It's going to haunt us. So God has given us this excellent opportunity where we are going an all-out surgical strike against the virus. We also need to enhance our systems, which actually help spread the virus. And then micro-elimination for all these small pockets that we talk about, the sex workers, the prisoners, the drug abusers. What are we going to do? And this, I think, in my judgment, and this is one of the missions of the PKLI, this gives us a tremendous amount of research opportunity for us. I mean, we have we look at all the Western data, we don't produce anything. So this gives us, to me, this is a gold mine of a research that can actually put Pakistan on the world map in terms of research and other things. And we're not talking about just the research. Why can't we build our own diagnostic RNA testing? India can do it. Why can't we do it? And, in Kolkata, that they have done this NAT RNA testing. They have developed their own system, which is going through the WHO pre-qualification. So our scientists are very bright. I think we need to, as a cohort, as a subject of research, while this project is going and we have millions of people there, I think we need to look at that as well. Clinical trials for reduced treatment, pediatric trials, development of an effective surveillance system to make sure that, and this actually gives us, just like COVID, this gives us a tremendous opportunity to really build in Center of Disease Control, which has a very good grip on our epidemiological data. I mean, that's a biggest missing link in my judgment in Pakistan. Funding opportunities, local, international donor agencies for hepatitis. What are the goals? Local entrepreneurs. Pakistan is a very entrepreneurial country. I mean, Pakistanis are the biggest donors in the world. So when we take this as a campaign to people who can pay for others' treatment, why shouldn't they pay for the other treatment? But it has to be made as a national issue, as a national mission, as a national cause, actually. And I strongly believe that all the burden should not be borne by the government. People who can pay should pay. Then we should absolutely, as a matter of legislation, we should make sure all these industries, the banks, they need to take care of their employees. I mean, they're making money through those employees. Why should they not take care of their health? So I think it's a matter of legislation that we need to bring in, where we make it mandatory for all the employers to take care of their employees. So the government does not bear all the expenses. All the industry owners, businessmen, etc. What should be the execution? I mean, this is the most key slide that I want to talk about. Mr. Minister, this whole thing is going to fizzle out if we don't create a very well thought out, very organized, and a very practical plan with all the stakeholders sitting together. All those $35 billion that you have pulled after a lot of effort, and I know what struggle you have gone through, that's going to go down the drain if it is not executed properly. So it is extremely important for all the brains that are sitting in this room to come up with a plan to look into all the goods and the bads and the ugly, to make sure that once we have just launched the thing and the bullet has been fired, the government has done its job. Now it's up to us as professionals to take charge of the situation. It's with the government and Dr. Achakzi is sitting here and all the other government officials, that we really sit down with the professionals and create a plan, a foolproof plan, put all the stakeholders on one table and then execute that plan. And this should be, again, we need to create technical groups. And then, countries have combined together to procure. Countries. And here we say, I will procure myself and you will procure yourself. We can bring the cost of all the diagnostic and therapeutics to pennies if we do that mass scale. We're talking about 9 million people here. I mean, in the whole world, as of today, combined, 9 million people have not been treated. So when we are talking about such a big burden of disease, you can get these companies to go into pennies and they will still make money. They will still make money if they give it to you at a very, very subsidized cost. But I think a very comprehensive and thoughtful plan needs to be made. And in implementation strategies down to the technical detail. Then we need to make sure that we have a very good surveillance system to make sure that what we think we have done, we have actually done. It's not we're just fooling ourselves that we have done. So there's a very good, and this gives you an opportunity to create a system of surveillance for all the communicable diseases. I mean, this will give you that infrastructure. This is the lateral collateral fruit that we can reap if we plan things right. And we look at it, and the drug resistance is a reality. I mean, we need to see what's happening. I mean, the data is coming from the West. So what is the relapse rate? So with that, I want to conclude my talk before we invite the next speaker by a couple of lines. Number one, I'm very grateful to the government of Pakistan. I'm very grateful to the Prime Minister of Pakistan, Mr. Shehbaz Sharif, for giving us unconditional support. I'm very grateful to Mr. Hassan Iqbal, the minister, for giving us unconditional support. Thank you, sir, for your ownership and the commitment. And I know what you had been doing, so I'm very thankful to you. I'm thankful to the Ministry of Health for taking the initiative and the planning division for taking the initiative. But I think the burden is up to you to take it to the final end. And again, and I'm very thankful to all the professionals who on a very short notice from overseas and from Pakistan, they're here under this roof to think of only one thing, that how the hell we get rid of this virus out of our community. Thank you very much.
Thank you very much, Dr. Saeed Akhtar. Ladies and gentlemen, and particularly international speakers and community, it is compelling to introduce that when you talk about strategy, when you talk about planning, when you talk about future development, whether this is an economic development, educational development, or a health development, the most heaviest figure or the brain you could think about is our honorable chief guest, Hassan Iqbal. We are very grateful on behalf of the PKLI. I would like to congratulate you for all the contributions, for the accomplishments which we had yesterday in launching the Hepatitis C campaign, as well as the PKLI University. Thank you very much, sir. Now it is the time to invite our chief guest. So please come up on the stage and share his future vision and the strategy of the government, that how this massive campaign is going to launch in future, what could be the best possible implications, how well it could be integrated, and how all the stakeholders could be united for a specified and a unified noble cause. Ladies and gentlemen, please welcome Hassan Iqbal, Minister for Planning and Development.
Bismillahirrahmanirrahim. Honorable Dr. Saeed Akhtar Saab, distinguished professionals, management of PKLI. First of all, let me compliment PKLI for taking this initiative. And after a very informed talk by Dr. Saeed Akhtar, I think a non-professional in this area, in this field, has little to say. But for a politician, if he has an audience and a mic and he does not speak, that becomes quite embarrassing. So nevertheless, taking advantage of this audience and the media. So let me also apologize to the foreign guests. I would prefer to speak in Urdu because this is a message we need to take to the masses and they must understand what we are suffering through. अभी मैं डॉक्टर फैसल ने बहुत एक जेनरस तारुफ कराया. मुझे वाकया याद आ गया कि एक साहब थे जो बहुत स्पीच करना पसंद नहीं करते थे. Let me share this joke in English also because our guests can also enjoy. There was a guy like myself who was not a good speaker. And every time he had this invitation for a public talk, he would readily accept it, but till that event was over, his, tension of having to face the audience and his jitterness would fall upon people around him. So their life used to be quite hell till this person was over with the event. So one day, one of his staff asked him, "Sir, we know speaking to people or the audience is not your piece of cake. And it puts you in a lot of misery and you make your people's life or people around you also miserable. I just wonder what is it that keeps it going for you? You keep accepting these invitations and you go through this lot of ordeal every time you do it." He said, "John, it is the pleasure of listening to the introductions." So फैसल साहब के बड़े जेनरस इंट्रोडक्शन ने भी थोड़ी तवानाई दी आज के दिन को अच्छा गुजारने के लिए. मैं ये कहना चाहूँगा कि आज हम एक डिफाइनिंग मोमेंट पे सुनते आए हैं कि खड़े हैं, लेकिन हकीकतन आई थिंक 75th इंडिपेंडेंस एनिवर्सरी का साल से हम गुजर रहे हैं और पाकिस्तान की जो डेवलपमेंट ट्रैजेक्टरी है उसके ऊपर बहुत से हमारे ऊपर जिम्मेदारियां हैं. क्या वजह है कि हम उन तमाम ममालिक से एक एक करके पीछे रहते जा रहे हैं जिन ममालिक को हम किसी ज़माने में अपने से बहुत पीछा देखा करते थे. हमारे अपने रीजन में देख लें, 2000 तक हिंदुस्तान हमसे बहुत पीछे था. 2013 से पहले बांग्लादेश भी हमसे पीछे था. वो दोनों ममालिक हमसे आगे निकल गए. क्या उनके पास कोई बहुत फरिश्ता नुमा क़यादत है? क्या उनके पास उनकी गवर्नेंस में कोई बहुत इनकलाब उन्होंने बर्पा कर लिया है? वही ईस्ट इंडिया कंपनी के जो उतारे हुए स्ट्रक्चर्स हैं, तकरीबन वही 1935 का एक्ट है जो इस खित्ते में बनाया गया बरतानवी राज में. उसी 1935 के एक्ट से इन तीनों ममालिक ने अपने आइन वज़ा किए और वही ब्यूरोक्रेटिक स्ट्रक्चर है. किसी मुल्क ने कोई इसमें खातर खा रेवोल्यूशन नहीं बर्पा की. सोशियो इकोनॉमिक प्रोफाइल भी 18-20 के फर्क से एक जैसे ही हैं. तो क्या वजह है कि वो मुल्क आगे निकल गए? अगर आप पिछले 50 साल की तारीख देखें, जापान से शुरू हो जाएं, कोरिया, मलेशिया, वियतनाम, सिंगापुर, थाईलैंड, बांग्लादेश, चाइना, इंडिया, टर्की, एनी कंट्री यू सी, आपको 3 चीजें तरक्की के लिए प्री रेक्विजिट नजर आती हैं: पीस, स्टेबिलिटी एंड कंटिन्यूटी ऑफ पॉलिसीज. जिस मुल्क में ये 3 चीजें नहीं होंगी, आप वहां पे नोबल लॉरिएट्स ला के बिठा दें, दे विल फेल. लेकिन अगर ये 3 चीजें आप किसी मुल्क में पैदा कर देंगे तो उसकी लीडरशिप अगर मीडियोकर भी होगी तो वो मुल्क को लेकर आगे निकल जाएगी. तो अब हमने जो 75 सालों में T20 के मैच खेले हैं अपने मुल्क के पॉलिटिकल मैनेजमेंट के अंदर, अब वक्त आ गया कि उससे जान छुड़ाई जाए. और मैं समझता हूं कि PKLI की कहानी और पाकिस्तान की कहानी बड़ी जुड़ी हुई है. आपने देखा कि PKLI का कैसे उठान हुआ. डॉक्टर सईद अख्तर साहब की क़यादत में اس ادارے نے ایک اپنا مقام کھڑا کیا, اپنی ایک حیثیت بنائی. اور مجھے یاد ہے کہ اس زمانے میں کئی لوگ مجھے آ کر کہتے تھے کہ جی ہم حیران رہ گئے کہ پاکستان کے اندر ایسا ہسپتال, ہم کئی امریکہ کے ہسپتالوں میں گئے ہیں, وہاں پر ایسی فیسلٹی ہمیں نظر نہیں آئی جو ہم نے PKLI کی صورت میں پاکستان میں دیکھی ہے. تو پھر کیا ہوا؟ وہی ہوا جو پاکستان کے ساتھ ہوتا ہے. اور میں آپ کو مثال تھوڑی ہو جائے گی کہ اگر ایک مریض آپ کے پاس یہاں پر آئے اور آپ اس کو بری حالت میں دیکھ کے فوراً ٹریٹمنٹ دیں اور اس کے انڈیکیٹرز امپروو بھی ہونے لگ جائیں اور وہ روبِ صحت ہونے لگے, تو اچانک کوئی کہے کہ نہیں جی بس وہ ایک گلاب دیوی اسپتال میں ایک ڈاکٹر ہے, بڑا ہینڈسم ہے, میں نے تو اسی سے علاج کرانا ہے. اس سے کوئی پوچھے کبھی لیور کا اس نے علاج کیا ہے؟ وہ جی علاج کیا نہیں کیا, لیکن ہے بڑا دیانتدار اور ہینڈسم, مجھے پسند بڑا, میں نے اسی کے پاس جانا ہے. تو وہ یہاں سے مریض اٹھا کے اگر گلاب دیوی اسپتال میں لے جائے ایک ایسے ڈاکٹر کے پاس کہ جس نے زندگی میں کبھی لیور کا پیشنٹ ٹریٹ نہیں کیا, تو اس کا کیا انجام ہوگا؟ تو یہی اسی قسم کا انجام کچھ ہمارے ساتھ بھی پاکستان میں ہوتا ہے. آپ کو یاد ہے کہ 2013 میں یہ ملک اس مقام پہ تھا کہ جہاں 16 گھنٹے بجلی نہیں تھی, ہر روز خودکش بمبار ہوتے تھے, اکانومی آلموسٹ پیرالائز ہو گئی تھی. اور 4 سال کی محنت کے بعد وی ریچڈ اے پوائنٹ جب ہم نے ویژن 2025 بنایا کہ بائی 2025 وی وڈ بی ان دا ٹاپ 25 اکانومیز. اس میں ہم نے یہ بھی لکھا کہ یہ سارے جو ہمارے چیلنجز ہیں, چاہے ہیلتھ سیکٹر کے ہیں, ایجوکیشن سیکٹر کے ہیں, اکانومی کے ہیں, ہر ایک کا KPI بنایا کہ کس طریقے سے ہم اگلے 10-12 سالوں میں ان کو ایڈریس کریں گے. اور ہم الحمدللہ اس روڈ میپ پہ چل رہے تھے. اور اسی روڈ میپ کے حصے میں 2017 میں ایک نیشنل فریم ورک بھی بنا کہ ہم نے کس طریقے سے 2021 تک اس پورے چیز کو اٹیک کرنا ہے. اور وہ نیشنل فریم ورک ایک گائیڈنگ ہمارا ڈاکومنٹ تھا یا روڈ میپ تھا جس سے ہیپاٹائٹس کو پاکستان سے ایلیمنیٹ کرنے کے لیے ہم نے کام کرنا تھا. لیکن جب ہم وہاں پہنچے کہ پرائس واٹر ہاؤس کوپر یہ کہنے لگ گئی کہ 2017 میں ان کی رپورٹ نے کہا کہ پاکستان از ویل پوائزڈ ٹو بی ان دا ٹاپ 20 اکانومیز بائی 2030. تو اس وقت ہمارے ساتھ یہی ہوا کہ اس مریض کو کہ جو ٹھیک ہو رہا تھا, چند لوگوں نے زبردستی اٹھا کے ایک انٹرینڈ ڈاکٹر کے پاس گلاب دیوی اسپتال میں یا فار دیٹ میٹر کسی اور اسپتال میں کسی اسپتال کا نام نہیں لینا چاہتا, داخل کرا دیا. اور آج آپ دیکھیے کہ ہم کہاں کھڑے ہیں. 2018 میں منسٹری آف پلاننگ کے پاس 1000 ارب کا ڈیولپمنٹ بجٹ تھا جس سے ہم یہ سارے انیشیٹیوز کو آگے لے کر جا رہے تھے. 4 سال کے بعد جب میں آیا تو ہمارا ڈیولپمنٹ بجٹ 550 ارب رہ چکا تھا. اور ان 4 سالوں میں جو انفلیشن ہے اس سے آپ ڈسکاؤنٹ کریں تو دیٹ وڈ بی 200 اور 250 بلین ان 2018 ویلیو. تو اس سے آپ کیا کر سکتے ہیں کہ 23-24 کروڑ کی آبادی ہے اور 550 ارب کا بجٹ ہے جس میں کہ بیمار پروجیکٹس کا ایک بڑا پورٹ فولیو ہے کہ جو پروجیکٹ ڈیلیز ہو رہے ہیں. تو ہم نے پچھلے 14-15 مہینوں میں پل صراط پہ چل کے کوشش کی ہے کہ ملک کی اکانومی کو دوبارہ ٹھیک کیا جائے. اور جو ہمارے پریسنگ چیلنجز ہیں ان کو ہم پھر فوکس میں لے کر آئیں. اور اس حوالے سے ہم نے 5 E's کا ایک فریم ورک بنایا کہ پاکستان کو کس طریقے سے ہم آئندہ سٹیبل کر سکتے ہیں. اس میں ایکسپورٹس ہیں, اس میں پاکستان ہے, اس میں انوائرمنٹ ہے جس میں واٹر اینڈ فوڈ سیکیورٹی ہے, اس میں انرجی ہے, اور اس میں 5واں ہے ایکوٹی اینڈ امپاورمنٹ کہ ہم اپنے شہریوں کو برابری کے مواقع ترقی میں کیسے دے سکتے ہیں. اور اس ایکوٹی اینڈ امپاورمنٹ کے 3 بیسک پلرز ہیں, ایجوکیشن, ہیلتھ اور پاپولیشن مینجمنٹ. ابھی جو حالیہ ہماری مردم شماری ریلیز ہوئی ہے, آج نوٹیفائی ہوئی ہے, پاکستان نے 2017 سے 2023 تک اپنی پاپولیشن گروتھ کو 2.38 سے بڑھا کے 2.55 کر دیا. یہ پہلی بار ہے کہ ہم 2080-81 سے ڈاؤنورڈ ٹریجیکٹری پہ جا رہے تھے، تو اب اس کو پھر ہم نے دیکھا ہے کہ پچھلے 5 سالوں میں وہ اپ ورڈ ہو گئی ہے، جس کا مقصد یہ ہے کہ ہمارے اوپر آبادی کا مزید دباؤ آنے کے لیے تیار ہے اور ہمارے وسائل بہت کم ہیں. تو اس لیے بڑی ہی ہمیں ذمہ داری کے ساتھ اپنے مستقبل کے فیصلے کرنے ہیں. تو پاپولیشن مینجمنٹ کیسے کرنی ہے، ہیلتھ کے ذریعے سوسائٹی میں ایکولائزر کیسے کرنا ہے، چونکہ یہ جو بیماریاں ہیں اس سے سب سے زیادہ غریب طبقہ متاثر ہوتا ہے. جب ہیپاٹائٹس میں اگر آپ پروفائلنگ کریں تو وہ طبقے کے جو ہمارے سوشو اکنامک پروفائل میں نیچے ہوتے ہیں، جب وہ اس سے متاثر ہوتے ہیں، ان کے پاس علاج کی سہولت نہیں ہوتی، ان کی جو اکنامک پروڈکٹیوٹی ہے وہ ختم ہو جاتی ہے، وہ مزید پاورٹی کے اندر چلے جاتے ہیں. تو اس لیے اگر ہم ایک ایکولائزر کرنا چاہتے ہیں تو ہمیں لوگوں کو ایک صحت کے ساتھ ہیلدی ممبر آف دا سوسائٹی بنانا ہے. اور اس کو جب آپ دیکھتے ہیں تو پاکستان میں جو 2 بڑے کلرز ہیں اس وقت، ایک ہیپاٹائٹس اور ایک ڈائبٹیز. تو جب ہم نے یہ 5E فریم ورک مرتب کیا اور اگلے سال کی ڈیولپمنٹ پلاننگ کی، تو ان دونوں کے لیے منسٹری آف پلاننگ اینڈ ڈیولپمنٹ نے 2 انیشیٹیوز بجٹ میں ڈالے، ایک پرائم منسٹرز انیشیٹو آن ہیپاٹائٹس اور ایک پرائم منسٹرز انیشیٹو فار ڈائبٹیز. ہمیشہ یہ ہوتا ہے کہ حکومتیں ان چیزوں کے اوپر تقریر کرتی ہیں، لیکن جب آپ بجٹ دیکھتے ہیں تو بجٹ خالی ہوتا ہے. ہم اسٹریٹجک مینجمنٹ میں پڑھتے بھی تھے اور پڑھاتے بھی تھے کہ اگر آپ نے کسی پروگرام کی پرائرٹی دیکھنی ہے تو آپ اس کا بجٹ دیکھیں، آپ اس پر لوگوں کی تقریریں نہ سنیں. کیونکہ بہت سی چیزوں پہ ہم تقریریں کرتے ہیں، لیکن اگر اس کے پیچھے ہم اپنے ریسورسز نہیں ڈالیں گے تو دو اسپیچز آر ویری ہالو. وہ صرف ایک ریٹورک ہے، اس میں کوئی عمل نہیں ہے. اس دوران ڈاکٹر سعید اختر صاحب سے بھی ہمیشہ ہمارے لیے رول ماڈل ہیں، ان کے کام نے ہماری رہنمائی کی. آئی مسٹ کمپلیمنٹ ڈاکٹر ہما صاحبہ بھی ہمارے پاس آئیں، اور خالد صاحب، عثمان صاحب بھی آئے، اور کئی لوگ جو اس فیلڈ کے ساتھ وابستہ ہیں وہ ہماری توجہ دلاتے رہے. تو ہم نے یہ پروگرام اس لیے بنایا ہے چونکہ یہ ڈیوالوڈ سبجیکٹ ہے، لیکن ڈیولوشن کا یہ مقصد نہیں ہے کہ فیڈرل گورنمنٹ کا رول ختم ہو گیا ہے. فیڈرل گورنمنٹ کا سب سے امپورٹنٹ رول ہے نیشنل کوآرڈینیشن، ویدر ڈیوالوڈ اور ناٹ ڈیوالوڈ. تو اس 2 پروگرامز کے ذریعے جو فیڈرل گورنمنٹ انٹینڈ کرتی ہے کہ ہم تمام صوبوں کے ساتھ مل کر ایک ویل کوآرڈینیٹڈ نیشنل کیمپین شروع کریں. چونکہ اگر آپ پچھلے ہمارے تجربے کو دیکھیں تو اس میں جتنی سٹڈیز ہیں اس میں ایک بڑا امپورٹنٹ فیکٹر جو کہا گیا ہے وہ لیک آف کوآرڈینیشن امنگ پروونسز اینڈ فیڈرل گورنمنٹ، اس کو ڈکلیئر کیا گیا ہے. تو یہ ایک بنیادی ضرورت ہے جو ہم چاہتے ہیں کہ اس کو ہم ایڈریس کریں. دوسری چیز یہ ہے کہ ہماری جو پہلے ویژن 2025 میں بھی اپروچ تھی اور اب بھی 5 فریم ورک میں ہے کہ جب تک کہ ہم ایک کولیشن آف سٹیک ہولڈرز نہیں اکٹھی کرتے، کسی بھی انیشیٹو کے پیچھے تمام کولیشن پارٹنرز اکٹھے ہو کر اسے اون نہیں کرتے، بائی ان نہیں لیتے، تو اس میں کامیابی کا امکان بھی بہت کم ہے. تو لہٰذا اس میں حکومت تنہا کچھ نہیں کر سکتی کہ جب تک اس میں پروفیشنلز بھی اس پروگرام کی اونرشپ لیں، انڈسٹری بھی اس پروگرام کی اونرشپ لے، کمیونٹی بھی اس پروگرام کی اونرشپ لے. اور اس میں ایک بہت بڑا رول ہماری سول سوسائٹی اور میڈیا کا ہے کہ جس کے ذریعے ہم لوگوں میں اویئرنیس پھیلا سکتے ہیں. اور یہ بات بڑی افسوسناک ہے کہ آج بھی ہمارے ہاں جو ہیپاٹائٹس کے پھیلنے کے ذرائع ہیں وہ ہیں کہ جو انتہائی کم ترقی یافتہ ممالک میں دیکھے جاتے ہیں. ہم ایک طرف ایٹمی طاقت بن چکے ہیں اور دوسری طرف ہم بیسک چیزیں کہ ہم جیسے ابھی کہا گیا کہ جو بلڈ ٹرانسفیوژن ہے اس میں اسکریننگ نہ صحیح کر سکیں، اور ہم اپنے سرنجز کو جو ہے ری یوز کر کے اس کے ذریعے پھیلائیں. ہم ڈینٹل پریکٹس یا کلینکس کے اندر لوگوں کو احتیاط سے ان کی حفاظت نہ کر سکیں، اور اسی طرح ہم اپنے بچوں کو پیدائش کے موقع پہ ویکسینیٹ نہ کر سکیں. یہ وہ ساری چیزیں ہیں کہ یہ راکٹ سائنس نہیں ہے کہ ایک ایسا ملک کہ جو ایٹم بم بنا چکا ہو وہ ان چیزوں پہ اگر سٹرگل کر رہا ہو تو اس کے لیے بڑے افسوس کی بات ہے. اور اسی لیے جب ہم نے ایٹمی دھماکے کیے تو میں یہ واقعہ سناتا ہوں چونکہ یہ اس میں بڑا سبق ہے. تو ڈاکٹر AQ خان اور ڈاکٹر اشفاق احمد میرے پاس اس کے بعد آئے کسی ایک پروجیکٹ کے لیے. تو میں نے ان سے کہا کہ یہ بات تو ہم بعد میں کریں گے جو آپ کا پروجیکٹ ہے, پہلے مجھے آپ ذرا یہ سمجھائیں کہ یہ ایک ایسا شعبہ تھا کہ جس میں دنیا کا کوئی ملک ہمیں مدد دینے کے لیے تیار نہیں تھا. رادر ہر ملک ہماری ٹیکنالوجی تک رسائی روکنے کی کوشش میں لگا ہوا تھا. ہمیں ہر طرف سے مخالفت کا سامنا تھا. اس شعبے میں ہم کامیاب ہو گئے, اور وہ شعبے کہ جس میں پوری دنیا ہماری مدد کرنا چاہتی ہے, ہمیں مدد بھی دیتی ہے, چاہے وہ صحت ہے چاہے وہ تعلیم ہے, اس میں ہم ناکام ہوتے ہیں. کیا وجہ ہے؟ تو آپ کی یہ کامیابی کیسے کیوں کر ممکن ہوئی؟ انہوں نے چند باتیں کی, میں سمجھتا ہوں کہ اس میں ہمارے لیے رہنما اصول ہیں. کسی بھی پروگرام کو کامیاب کرنے کے لیے وہ اگر 5-6 چیزیں ہم یقینی بنائیں تو اس کے نتائج حاصل کیے جا سکتے ہیں. انہوں نے کہا کہ دیکھیے, پہلی بات یہ ہے کہ ہم اس لیے کامیاب ہوئے کہ ہماری آرگنائزیشن میں چیئرمین سے لے کر خاک روب تک, بس کے ڈرائیور سے لے کر پرنسپل انجینئر تک, ہر شخص میں ایک سینس آف مشن تھا کہ میں ملک کے لیے ایک بڑے اہم پروجیکٹ کا حصہ ہوں. چاہے وہ خانسامہ تھا, چاہے وہ ڈرائیور تھا, چاہے وہ نائب قاصد تھا, وہ بھی خود کو ایٹم بم بنانے کا ٹیم کا اسی طرح حصہ سمجھتا تھا جیسے پرنسپل انجینئر تھے. تو ایک مکمل آرگنائزیشن کی بائی ان تھی, ایک شیئرڈ سینس آف مشن اور پرپز تھا, اور ایک گول تھا جس کے ساتھ پوری آرگنائزیشن الائن تھی. تو لہٰذا یہ ایک بڑا اہم قیمتی اصول ہے کہ جب تک ایک شیئرڈ گول اور ایک اتفاق سب کا نہ ہو کہ ایک پرپس کے اوپر ہم سب نے مل کے چلنا ہے, آپ کامیاب نہیں ہو سکتے. سیکنڈ چیز انہوں نے کہی کہ ہمارے چیئرمین جتنے تھے وہ 6 سے 8 سال انہوں نے سرو کیا, تو وی ہیڈ کنٹینیوٹی اینڈ اسٹیبلٹی آف لیڈرشپ. اور اس پہ ڈاکٹر AQ خان نے ہنس کے مجھے کہا کہ اگر ہمارے چیئرمین بھی آپ کے وزیر اعظموں کی طرح بدل رہے ہوتے تو ہم نے آج ایٹم بم نہ بنایا ہوتا بلکہ پھل جڑی بنا کے بیٹھے ہوتے. تو بڑا ہی کرٹیکل ہے کہ جو آپ کسی انسٹیٹیوشن یا پروگرام کو لیڈرشپ میں اسٹیبلٹی دیں, اور تاکہ کنٹینیوٹی اس کی ہو, اور وگرنہ وہ پروگرام متاثر ہو جاتا ہے. تیسری چیز انہوں نے کہی کہ ہم نے کبھی میرٹ پہ کمپرومائز نہیں کیا, ہماری ہائرنگ میں, پوسٹنگ میں, ٹرانسفر میں, اور ہم نے میرٹ بیسڈ آرگنائزیشنز بنائی جس سے ہمیں نتائج ملے. چوتھی چیز انہوں نے کہی کہ ہمارا بم مشینوں نے نہیں بنایا, ہمارا بم انسانوں نے بنایا. تو وی انویسٹڈ ان ہیومن ریسورس ڈیولپمنٹ. اٹ از پیپل ہو ڈیلیور, کہ آپ اپنے اداروں میں اگر لوگوں میں انویسٹ کریں, ان کی صلاحیت کو اجاگر کریں, تو وہ مشکل سے مشکل مسئلے کا حل نکال لیتے ہیں. پانچویں چیز انہوں نے کہی کہ اگر ہمیں حکومتوں نے ایک مشن دیا تو اس کے وسائل بھی دیے. یہ نہیں کہ ہم فائل پکڑ کے سیکشن افسر کے دفتر کے چکر کاٹ رہے تھے کہ جی یہ ریلیز ہماری آئے گی, بجٹ ملا کہ نہیں ملا. تو ہمیں بجٹ بھی دیا گیا اور ہم نے یکسوئی کے ساتھ اپنا کام کیا. اور آخری چیز انہوں نے کہی کہ اگر ہمیں وسائل دیے تو اس کے ساتھ ایک فنکشنل اٹانومی بھی دی. یہ نہیں ہے کہ روز ایک آڈٹ پیرا لگ کے تو ادھر ہی ہم پھر رہے ہیں, اور ہم اپنا کام کرتے تھے, اور ہمیں ایک اپنے دائرے کے اندر فنکشنل اٹانومی دی گئی تاکہ ہم اپنا مشن پورا کر سکیں. میں سمجھتا ہوں کہ یہ وہ رہنما اصول ہیں کہ کسی بھی پروجیکٹ میں, کسی بھی پروگرام میں لگائے جائیں تو نتائج حاصل کیے جا سکتے ہیں. تو میں آپ سب کو مبارکباد دیتا ہوں اور یقین دلاتا ہوں. افسوس یہ ہے کہ وی ہیڈ ویری لٹل ٹائم. ہم نے ان 15 مہینوں میں کوشش کی ہے کہ پاکستان کو, اس کی سمت کو تبدیل کیا جائے, پاکستان کو ٹرن اراؤنڈ کیا جائے. اور اس ٹرن اراؤنڈ کی سب سے بڑی KPI یہ ہے کہ آج سے 14 مہینے پہلے دنیا میں اور پاکستان کے اندر لوگ اس بات پہ شرطیں لگا رہے تھے کہ پاکستان 2 ہفتے میں ڈیفالٹ کرے گا یا 4 ہفتے میں ڈیفالٹ کرے گا. آج دنیا کے کسی حصے میں کوئی یہ شرط نہیں لگا رہا کہ پاکستان کیا 2 سال میں یا 4 سال میں ڈیفالٹ کرے گا یا 10 سال میں ڈیفالٹ کرے گا. آج پاکستان کے بارے میں دنیا کی پرسیپشن سٹیبل ہو گئی ہے کہ پاکستان از ناؤ آن پاتھ آف ریکوری. اب ضرورت اسی بات کی ہے کہ اگر ہم نے اس ریکوری پاتھ پہ چلنا ہے, ان انیشیٹوز کو لے کے چلنا ہے, تو اگلے 5-10 سال کے لیے ہم دل و دماغ سے فوکسڈ ہو کے ایک سنگل پرپز کے ساتھ اس پاتھ پہ سیدھے چلیں. کیونکہ پالیسیز جو ہیں وہ 10 سال سے پہلے نتائج نہیں دیتی. پروجیکٹس, پروگرامز 5 سال 3 سال میں کامیاب ہو جاتے ہیں, لیکن دنیا میں کسی ملک نے جس نے ترقی کی, آپ دیکھ لیں, اس میں 10-10 سال کے پیریڈز ہیں کہ جس میں وہ سٹیبلٹی اور کنٹینیوٹی. ہمارا ہمسایہ ملک ہے, بی جے پی اور کانگریس کی 2 ٹرمز کی حکومتیں ساری رہی ہیں, کسی حکومت نے 10 سال سے کم کا عرصہ نہیں کیا. نتیجہ کیا ہے کہ وہ پالیسیز گراؤنڈ ہو جاتی ہیں اور اس پھر اگلی حکومت آتی ہے, وہ ان کو لے کے آگے چلی جاتی ہے. لیکن اگر یہی ہم ایک میوزیکل چیئر کھیلتے رہیں گے تو 2 قدم آگے جاتے ہیں, 6 قدم پیچھے چلے جاتے ہیں. میرا خیال ہے کہ اس سے نتائج ہم کتنے بھی سیمینار کر لیں نہیں نکل سکتے. ہم سب کو کیور پتہ ہے, ہم سب کو حل پتہ ہے. وہ اسٹینفورڈ یونیورسٹی کے پروفیسرز ہیں, ان کی ریسرچ تھی کہ جو ایک بیمار آرگنائزیشن ہے اور صحت مند آرگنائزیشن ہے, اس میں فرق یہ ہوتا ہے کہ there is a knowing doing gap in sick organization. They know a lot, but they have little incentive to implement what they know to fix those problems. And then the organization becomes a sick organization. Because its rules, its incentive structures are such that they favor status quo. اور آپ وہ ساری نئی انوویشن, نئے خیالات جو آپ کو پتہ ہیں کہ کرنے چاہیے, ان کے لیے انسینٹیو نہیں ہوتا, اس کے لیے کوئی راستہ نہیں ہوتا کہ آپ اس کو امپلیمنٹ کریں. تو اس لیے اب ہمارے لیے میرا خیال ہے ضروری ہے کہ یہ تمام جو معلومات کامن سینس ہیں, ایجپٹ یہاں بیٹھے ہیں, انہوں نے کر لیا ہے, تو if Egypt can do, why cannot we do? So it only requires commitment from top to bottom, taking this as a national challenge. اور ایک ملک جو ایک ایٹمی طاقت بن سکتا ہے, کیا وہ اس کو نہیں ختم کر سکتا؟ بالکل کر سکتا ہے, لیکن یہ اس طرح نہیں ہوگی کہ ہم اس کو صرف ایلیمینیٹ کرنے پہ سوچیں. ہمیں اس کے جو روٹ کاز ہے اس کو بھی پلگ کرنا پڑے گا. یہ اسی طرح ہے کہ آپ ایک کسی تالاب کے اندر ڈی واٹرنگ شروع کر دیں, لیکن جو ٹیپ ہے جس سے پانی آ رہا ہے اس کو بند نہ کریں. So we have to do both things simultaneously. تبھی جیسے ڈاکٹر سعید صاحب بھی کہہ رہے تھے, فائدہ ہوگا کہ وہ تمام سورسز جہاں سے یہ پھیلتا ہے اس کو بھی ایک وار فوٹنگ پہ پلگ کرنا ہے, اور ساتھ میں جو یہ پریویلنس ہو گئی ہے اس کو بھی ہم نے ٹریٹ کرنے کے لیے ہنگامی اقدامات کرنے ہیں, اور اس کے لیے انہوں نے آپ کو بتائیں, جس سے آپ کی جو اجتماعی وزڈم ہے اس سے ہمیں روڈ میپ ملے گا. And I assure you, although our government will finish its term in next 3 days, but I'm pretty sure کہ جو باتیں آپ سجیسٹ کریں گے اور ریکمینڈ کریں گے, جو کیئر ٹیکر گورنمنٹ آئے گی وہ بھی اس کو لے کے چلے گی. اینڈ آئی سنسیئرلی ہوپ کہ اللہ تعالیٰ ہمیں دوبارہ موقع دے تو ہم فل تھرسٹ کے ساتھ الیکشن کے بعد بھی اس پروگرام کو آگے لے کے چلیں, چونکہ دس از اباؤٹ آر سروائیول. یہ نہیں ہو سکتا کہ ایک ملک دنیا کے سب سے بڑے برڈن کو ہیپاٹائٹس کے اپنے کاندھوں پہ اٹھا کے کھڑا ہو اور وہ یہ خواب بھی دیکھے کہ ہم ایک بہت ترقی یافتہ ملک بن جائیں گے. جب تک ہم ایک صحت مند قوم پیدا نہیں کریں گے ہم ترقی میں بھی کامیاب نہیں ہو سکتے. اور اس کے لیے ہیپاٹائٹس جیسے مرض کو ہمیں پاکستان کے دھرتی سے ختم کرنا ہے, ڈائبٹیز جیسے مرض کو جو ایک سائلنٹ کلر ہے اس کو ختم کرنا ہے. ان دونوں میں ہم دنیا میں میڈلز لے چکے ہیں, گولڈ میڈل لے چکے ہیں ان کو پھیلانے میں, تو وہ ہمیں میرا خیال ہے. اور اسی طرح پاپولیشن مینجمنٹ جو ہے اس کے یہ وہ چیزیں ہیں کہ جن کے اوپر اب بحث ہونی چاہیے. بحث اس کے اوپر نہیں ہونی چاہیے کہ ایک دوسرے کو کتنی گالیاں دینی ہیں, بحث ہونی چاہیے نیشنل ایجنڈاز کے اوپر, ہم نے کس طریقے سے بیماری کو ختم کرنا ہے. پہلی دفعہ ہم نے پاکستان میں آؤٹ آف اسکول چلڈرن کے لیے 25 جیسے یہ ہیپاٹائٹس کا فنڈ مختص کیا ہے, 25 ارب روپے کا فنڈ مختص کیا ہے. صوبائی حکومتوں سے کہا ہے اس میں 25 وہ ڈالیں, اور ڈیولپمنٹ پارٹنر سے کہا ہے کہ 25 وہ ڈالیں, تاکہ 75 بلین سے ہم اپنے تمام بچوں کو اسکولوں میں لائیں, جس کے لیے ارلی چائلڈ ہوڈ ایجوکیشن کو بنیاد بنائیں. اسی طرح ہیپاٹائٹس میں بھی जो हमारी 34 अरब का ये प्रोग्राम है, मैं समझता हूं कि इसमें अगर 34-35 अरब सूबाई हुकूमतें कंट्रीब्यूट करें और 34-35 अरब हम डेवलपमेंट पार्टनर से दें, और अगर हम दोनों सूबे और वफाक इसमें अपना 70 अरब डाल देंगे तो डेवलपमेंट पार्टनर्स में भी थ्रिल्ड कि वो भी उसमें बड़ी खुशी के साथ 35-50 अरब और डाल देंगे। तो ये 100 बिलियन प्लस का अगर हम फंड रेज करके इस कैंपेन को शुरू करें तो मुझे यकीन है कि हम 3 सालों के अंदर पाकिस्तान से हेपेटाइटिस को खत्म कर सकते हैं। आई विश यू वेल एंड आई लुक फॉरवर्ड टू रिसीविंग रिकमेंडेशंस ऑफ योर प्रोग्राम। और कल तक या परसों तक अगर मिल जाएंगी तो उसके ऊपर मैं भी अपना दस्तखत करके जाते जाते वजारत मनसूबाबंदी को ये हदायत कर जाऊंगा कि वो इस प्रोग्राम को इन सिफारिशात की रोशनी में जारी रखें। पाकिस्तान जिंदाबाद।
Thank you very much, Mr. Hassan Iqbal, for such a comprehensive talk on the topic of viral hepatitis. For my international guest, I just would like to emphasize a few important points. Hassan Iqbal did mention that it is very essential that as a nation, wherever the issue or challenge is, you recognize that issue. You need to put a drive in that issue. You need to motivate all the stakeholders for a unified cause. So that is one of the important pillars he mentioned, which can lead to the success. Second point, I think, which is worth mentioning, is the recognition at the government level that there is an issue, it's a challenge which needs to be dealt with. And I'm very glad, Mr. Hassan Iqbal, that government has acknowledged, government has a clear vision and a plan. And it's not only a plan, and he kindly mentioned that government is committed to pledge a budget for this noble cause. And thirdly, you very kindly mentioned we need a very sustainable instruments, tools, a management and governance, which is autonomous and independent, which might have all the provisions and the rights to exercise all necessary initiatives for implementation and execution of the mega project. Once again, on behalf of the PKLI whole management, all healthcare professionals are sincerely grateful for his very sincere initiative taken by your ministry at the government. Ladies and gentlemen, please clap for His Excellency, Mr. Hassan Iqbal, for great contributions. Moving on swiftly, our next speaker is Dr. Basir Khan Achikzai, and he is the Director General Health at the Ministry. Ladies and gentlemen, he's the key person responsible for all the interventions in the health sector. His major responsibilities also include to collaborate with all the stakeholders, integrate, liaise with the agencies, WHO, etc., and to talk to the implementation bodies. So he has a vast experience in the field of communicable diseases. He has a clear strategy, and he will be talking about HCV challenges and Prime Minister commitment to elimination of viral hepatitis from Pakistan in the coming few years. Please welcome Dr. Achikzai.
Thank you, sir. Bismillahirrahmanirrahim. Professor Hassan Iqbal Saab, Honorable Chairman PKLI और पोडियम पे जितने बैठे हुए मोहतरम हज़रात हैं, अस्सलाम वालेकुम। एक्चुअली प्रोफेसर साहब ने दरिया को कुज़े में बंद कर दिया। I think I don't need to say anything about that, how what is hepatitis or how it would manage। ये सारी उन्होंने फलसफा भी बयान कर लिया और उसका हल भी बयान कर लिया। मैं रास्ते में जब आ रहा था तो मैंने कहा मैं एक अक्ल की बात, मैं अपने अक्ल से एक अक्ल की बात प्रोफेसर हसन इकबाल साहब के सामने रखूंगा, और बड़ा खुश हो रहा था कि ये बात उसको नहीं पता होगी, लेकिन उन्होंने जाते जाते वो बात कर ली तो मेरा सारा वो ख़त्म हो गया। वो ये कि when I was in World Health Assembly, so the focus was, sir, and the discussion over there on with the Global Hepatitis Fund, and there are few witnesses were here. When we start discussion on that where Pakistan stand and what the Pakistan response is, so आई थिंक मेरे ख्याल में वो जो गोरा था और अंग्रेज था वो पठान लग रहा था। उन्होंने कहा पहले खुद कुछ करके दिखाओ फिर हम कुछ करेंगे ना। तो he was telling me that if there is any commitment from the government side, so rest assured you contribute, your contribution should be 20%, 80% we will contribute. And sir, I was near to bring some funding, but there was some issue between Saudi Arab and the Egypt policy maker sitting over there, and their top priority was that any country, especially 4 or 5 countries who has their own planned PC1s or commitment by the federal government and the provincial government, so that fund will be definitely supporting them. So I just, sir, wanted that you just said that, yes, there should be something from the federal government. But I need, sir, one promise from you, because we had a working experience with your good self, and I was the flood in charge, and you are chairman over there from the Ministry of Health, and you are main of action. सो जाते जाते सर एक बात सर, बाकी हमें इस निटी ग्रिटी में नहीं पढ़ना चाहिए, हमें आपकी एक सिग्नेचर चाहिए सर, और दैट सिग्नेचर इज दैट यू आर कन्विंस्ड। और प्रोफेसर साहब ने आपको अभी तमाम चीज़ें बता दी प्रोविंसेस की तरफ से। सर मेरे सारे चारों प्रोविंसेस के चीफ यहाँ बैठे हुए हैं। वी वर इन कंटिन्यूसली टॉक विद द प्रोविंशियल सेक्रेटरीज, लेकिन प्रोविंशियल सेक्रेटरीज ने जो प्रोविंशियल प्रोग्राम मैनेजर्स को भेजा है सर, they are doing it themselves। नॉन डेवलपमेंट साइड पे सिंध प्रोग्राम का मैनेजर बैठा हुआ है, पंजाब का, बलूचिस्तान का और खैबर पख्तूनख्वा का। they are already doing it sir, but if we are going the name of the national program, so we must do something in the shape of commodities or in the shape of commitment. So I'm not going sir in further more detail. The only thing is that 3 things you have asked from us. Number 1 is to make a NCOC style of a management team that is there in the PC1. And you ask us that all the stakeholders were here, sir. I think more than 20 people in the podium here and there. They are the high-tech people who are part and parcel of my technical working group, which we chair in the Ministry of Health. They have all their inputs in this PC1. Number 2. Number 3, you had said that the provincial contribution is in the shape of their ongoing activities and their ongoing fundings, which is very much there. और सर आखिरी बात जो आपकी तरफ से जो एक वही है जो फेडरल गवर्नमेंट का रोल है, बाय ऑल मींस वो कोई भी सुबह उसको डिनाई नहीं कर सकता है, चाहे डिवोल्यूशन हो या जो भी हो। इंटरनेशनल कमिटमेंट हमारी हैं, और इंटरनेशनल कमिटमेंट फेडरल मिनिस्ट्री करती है विद रिगार्ड टू डेटा और एनी सर्विलेंस एक्टिविटीज एंड मॉनिटरिंग एक्टिविटीज। वी हैव मेड सर्टेन टीम्स in consultation in the technical inputs from each and every province and each and every stakeholder and even the industry, because without the support of industry we cannot do anything. I thank you, sir. Thank you so much, sir.
Ladies and gentlemen, we are grateful for very kind time of the Honorable Minister. In view of time constraints, this is the time to officially recognize the contributions and the efforts and the commitments made by the Honorable Minister. So I would like to request the Chairman Board of Governors, the Dean of the institutions, to please come in front of the stage to honor the Honorable Minister. And here I would like to also mention and thank you Honorable Minister. I would Ihsan Iqbal Sahib, Ladies and gentlemen, we would like to continue our program, so please kindly take your seats. I would like to request Dr. Amara Naveed, who is the consultant hepatologist at PKLI, to take the further sessions on.
Thank you, everyone, for being here today. We're going to get started with our program. Our next speaker is Dr. Naveed Janjua. He has sent us a recorded talk, and he's going to be available online for a question hour. Not for question hour, for 5 minutes of the question sessions. So Dr. Naveed Janjua is an epidemiologist at the Executive Director of Data and Analytical Sciences at British University of Columbia in Canada. He is also a clinical professor at the UBC School of Population and Public Health. He has worked extensively on HCV epidemiological data, both for Pakistan and abroad. He has been working with us since 2017 and has been mentoring and guiding our program. He couldn't be here today, but has been kind enough to send his recorded talk. So he's going to be talking about the hepatitis C burden in Pakistan and the cascade of care. That's just me again, in case you're getting confused. That's not Dr. Naveed Janjua. So as our audiovisual team figures it out.
In our medical setting, we will need to reduce unnecessary injection. We will need to improve safety of injection as well as
Thank you, Dr. Naveed, for a very nice talk. We actually have Dr. Naveed Janjua online, so we're going to open up the house 2 minutes for questions. Dr. Naveed, can you hear us?
Yes, I could hear you.
We're going to test sound one more time. Dr. Naveed, can you hear us?
Yeah, I could hear you very well.
Perfect. We can hear you too. So any questions? You can raise your hand and there is a person who has a mic. Or maybe a comment from Dr. Huma. Dr. Huma को भी mic दे दें.
Thank you, Dr. Naveed. Really enjoyed your talk. And just wondering that, like in Pakistan, we also have this disease Yeah. So we have now some data also coming from children, and we were wondering that, you know, like we don't have any formulations for children in Pakistan. So the question is that for the time being, should we really kind of put them aside and wait for them to become like, you know, adolescents and then treat them, or should we really work on the formulations for children? Thank you.
I think that we should work with pharmaceutical companies to bring formulation for children's. As we see, although it takes a very long period to develop chronic liver disease and complications, but if we are able to treat children right now, we could reduce damage to their liver. So I think like the major effort should be to bring pediatric formulations in Pakistan. We should work with Gilead and AbbVie to have these formulations available in Pakistan and get these started in among children.
Thank you so much, Dr. Naveed. We're actually going to close the questions here, and then we'll move forward because we're short of time. Thank you, Dr. Naveed, for joining us online.
Okay, thank you very much. Really appreciate it.
Our next speaker needs no introduction, but for those of you who may not have heard of her before, which is very unfortunate, but Dr. Huma Qureshi. Dr. Huma Qureshi is the national lead and focal point person on the prevention and control of viral hepatitis in Pakistan. She recently retired as Executive Director of Pakistan Health Research Council, Islamabad. She led the initial 2007 National Survey of Prevalence of Hepatitis B and C, which was critical in establishing the Hep C baseline data in Pakistan. In 2017, she developed the National Hepatitis Strategic Framework. And then also in 2018, she developed the National Hepatitis C Testing and Treatment Guidelines. In 2019, as a WHO consultant, she developed the Afghanistan Hepatitis C Testing and Treatment Guidelines and the Hepatitis Strategic Framework. For her tireless efforts towards research, she was decorated with the Tamgha Imtiaz. So Dr. Huma Qureshi.
Thank you, Amara. All right, thank you. So I would probably say that, like S.N. Iqbal said, that I enjoyed the introduction because I didn't know quite a few things that she told. So thank you very much. And I'll straight away go to the slides and I have to move it. So that's my disclosure that I'm supported by the organizers for this talk. The contents of my presentation is that I'll show you the current burden of hepatitis C in Pakistan. What are the figures for the provinces? How many have been tested and treated? What are the challenges and what are the way forward? So as you all know, ladies and gentlemen, now Pakistan is the country with the largest hepatitis C burden in the world. And currently we have a prevalence of 7.5%. So with this, we stand as the largest burden country in the world. And as you all know that the hepatitis C is a silent killer. So if we don't diagnose these people very early, then many of these people would really go towards cirrhosis and will develop liver cancer. And what we see nowadays is this: Pakistan is also facing a liver cancer epidemic. And every 20 minutes, a Pakistani dies of hepatitis C related complications, may it be cirrhosis or may it be liver cancer. So it's a really, dreadful disease that apart from the chronic hepatitis, we also have a large burden of hepatitis C. So Dr. Dar, that's for you. Now we are facing a liver cancer epidemic. So be prepared for this, because that's what's going to come back to all of us who are really doing work on the liver cancer. So this is the prevalence data for hepatitis C, which was done by Homi Razavi in 2022 for Pakistan. And you see that currently we have, this is the number of patients or people who have the virus or have viremia. So these are about 9.7 million people who have the virus. We are not talking about anti-HCV, we are talking about people who might be PCR positive. And of these people, majority are in Punjab, almost about 6 million people, and about 2 million people then in Sindh. So these two provinces are actually facing the major brunt of the disease, and followed by other provinces. And this is probably the most prized slide, that, you know, this is the bucket of Hep C infections that we have, 9.8 million. And then we are adding about 4.7 million every year. And we are treating about half of these new infections. So if you are adding 0.4, we are treating 0.2. So we are just treating 50% of the new infections. So this 50% is adding on to the already existing pool. And then there are about 161,000 deaths which are occurring every year. So if you make a pool, it says that for the total number of HCV infections in Pakistan will obviously increase over time, because we have got more new infections and as compared to those who are cured or who die. So this pool is going to increase if you don't really stop this tap. So this is again developed by Homi Razavi from CDA, and it says that there is some progress which has been made by Pakistan over the past few years. And as you all saw, that the best years for us was 2017 and 18, where Pakistan really made very good progress, but then we were caught up with the COVID like the whole world. And then the tempo really slowed down. So we have 9.8 million people who have this virus. And we have so far diagnosed 30%, although we are supposed to diagnose 90%, and we have treated about 16% of those. So for 80% who need to be put on treatment, so far our target for treatment is really very, very low, and we really need to catch up on the diagnosis and treatment. So the challenges, as my talk really encompasses on, is the first challenge, which I think is the paper-based data. We have this paper-based data which has no authenticity. You can't check it. You can't really validate it. So we need to really go on electronic data. And for this, I must salute Punjab, because they're the only province so far which are doing the electronic data entry. And this needs to really go on, not only in the provincial programs, but even in the private sector, because we need to collate and bring all this data so that we really can go into the elimination. We need all these numbers. Then, as you all know, that it's a silent killer. So there's a large population who is not aware of the disease. So we really need to make people aware of this disease so that they really understand it and come out for testing. So for this, we need to really make large mass campaigns about awareness so that people come out. And for this, apart from the public sector, we need to engage the private sector, because 70 to 60% population still seek help from private sector. Then again, the issues of the low middle income country, you would all know that the population is poor. Most of the people live in, in remote areas. And the first line of, for a health-seeking behavior, the first line where they would go is a basic health unit or a rural health center. And unfortunately, most of our RHCs and BHUs have an issue of human resource. They have issues of power supply. Many of the RHCs and BHUs do not have even electricity, not to talk about internet and the equipment. So, if we are making this plan, Dr. Said, we need to really strengthen our RHCs, BHUs, and the Taluka hospitals, because the population is going to come to that site. And, people have lost faith in the government, frankly. So, if we are not prepared and they go to these sites and these sites are not really catering for them, then this program is going to flop. So we really need to really make efforts on strengthening out these things, and obviously engage the private sector to help us out in decreasing this burden of people who will come there. Then obviously this PCR testing and reporting, again, the issue is that many a times the PCR reports come in a month's time. Nobody would wait for a month to get starting the treatment. So we need to really scale this up and bring this testing and treatment of a PCR to maybe a day or two, a maximum of 3 days, because people can't wait that long. They will use your facility, get the test done, but then they'll go to the private sector somewhere else to get the treatment. So that's a wastage of your resources. And then for the treatment, again, I would say that there's an issue that who should be treated, who should dispense the treatment. So as our guidelines say that we can all the time engage the health care workers, which could be a nurse or a technician or a doctor. So primary care physician can actually dispense the drug, or maybe a nurse. And this is like decentralization and task shifting that WHO says. And for this, again, we need to engage the private sector. And then, like what this again, CD has calculated for us that to eliminate hepatitis from Pakistan, we need about $350 million in the next 8 years to successfully control the hepatitis C epidemic. And when we invest into this, then obviously once the people get tested and treated, the hospitalization costs will go down, and this will offset the investment that we would initially make. So this is what this diagram is trying to show you, that initially when you invest this 350 million, there's a lot of money going in there. Then this all money is going for the testing and the treatments, and with a very small cost going into the screening. But once you invest into this, then you see that this being a curable disease, your hospitalizations go down, your testing and treatment costs go down, and you ultimately save a lot. And this is again what the investment is going to really take you through, that once if you don't invest, then your disease goes up 20% by 2035. But once you make this investment of $350 million, your disease really goes down, and this burden and this investment goes down by 70%. So this is a huge, and this is again done by the modeling experts, Homi Razavi and their team. So that's the investment which is showing how much we are going to ultimately save. And this is what the savings are coming, not only as a GDP, $3 million, which is coming as a saving, but also the disability and the years of life lost. So again, this is, we all know that for to achieve this elimination of Hep C by 2030, we need to diagnose 90%, and we need to diagnose 80% and then treat 90%. So how would we achieve this? And this is the analysis which has been done by Homi Razavi and another by Peter from Bristol University. And they suggest that every year Pakistan has to treat 1 or 1.2 million people every year. And currently we are not even reaching 250,000. So that's a real low number. And to achieve this, we really need a lot of investment. And once these investments come in, and the whole Pakistan needs to treat about 1.2 million every year for the next 10 years to achieve this target. So that's why we thought that there's a dire need, because the provinces alone can't do it. It's a massive problem. So this program you all heard yesterday was launched by the Prime Minister yesterday. And this is approved for a 335 billion Pakistani rupees funding. And the provinces shall enhance their funding. And then again, because a lot of people thought that it's a vertical program, but it's not a vertical program. It's an add-on to the already existing provincial hepatitis programs, where the federal government shall procure the commodities and will pass it on to the provinces as per their needs and the key performance indicators, because obviously if a province is performing well, they would be given more funds. And obviously we'll try to get some funding from our donors and multilateral partners. So in conclusion, ladies and gentlemen, we all know that Pakistan has the hepatitis HCV infection in the world. There are about 10 million people who are awaiting diagnosis and treatment. And we add almost 400,000 new cases every year, but we treat only 50%. There's a need to reduce new infections. challenges are many, as I told you. I'm sure there are more, but then we need to address these, and these can be addressed. We have more new technologies coming in. We have got now new the dry blood samples, the plasma suppression cards, and these things are available where we can really transport the sera and the tests very easily. We can engage the private sector. We need to engage the private sector. We need to engage the CSOs, the hospitals, the labs, because they are our biggest partners. And that's where most of our healthcare people seek behavior seeking goes to the private sector. And we all know that together we can eliminate hepatitis C from Pakistan. And this is the slogan of this year's Hepatitis Day by WHO. That's one liver, one life. So we must save the life. And for this, we must have to save the liver. Thank you very much.
Thank you very much, Dr. Huma. May I request if you could stay here or take the mic? You can go there.
Okay.
Madam, mic लेके आप पाँच चलिए. Yes, there's a mic. So we're going to take questions. We're going to keep questions to 3 minutes, please, because we're running
Right.
a little short.
So I think you pointed out very eloquently, and I think this is beyond any question. The study from India by Agarwal and his group, they claim that in 2 years, you see the return of your investment. So I think it's money well invested. I think from the whole concept, one thing is starting to emerge in my mind, that people going from one doctor to the other doctor, doing tests here, doing tests there, it's not going to work. We probably used to use NADRA database, trace every human being through, and we'll ask Dr. Vakid to comment on that also, how they did in Egypt, but trace everybody through a unique identifier number. So no matter he goes, a guy from Lahore goes to Islamabad or Islamabad goes to Karachi, he's a traceable person in terms of his disease and can be followed up. I think that should be a very important part of our, when we plan how we're going to do it, it's not going to work without that.
Yeah, so frankly, Dr. Said, it was there in the slides. I didn't actually say it because there were time constraints, so, but it's there. It's not even if the people are moving from one province to other, it is within the same province because they go from me to you and from him to him. So we need to track, and we really need to see that, they have been treated or tested, or have they been linked to the care or not. So yes, NIC is there. It has to be there. And there's no second thought about it.
Right. So I think that technology will probably play a very, very important role. And before we embark, we need to create a tech platform that can probably cater to all these needs.
There's a question from Dr. Arif. Dr. Arif, okay. Dr. Man has a question.
I mean, it's a very important point you have made about NIC and NADRA, that we have got COVID vaccination on it, polio vaccination now on it. Can we also have hepatitis B vaccination on it? And along with that, can we make think about it? I mean, it's a bit of an outward thing, draconian. Some people have told me that, when you go to make your NIC, you need to get your PCR done for hepatitis C. And, that's how you get it screened. Or when you go to a hospital outpatient department or inpatient, you get screened without asking for it. And you have your NIC number, and that gets registered on NADRA. Or when you get into a university or in an office as a new employee, all of them can help put the data on NADRA. And when we know the numbers, then we'll be able to treat them, I guess. That will be the first step. Just a thought.
Yeah. Actually, that would be like a driving license, that wherever you go, they use a driving license. But I think for us to start with, the COVID experience was another linked testing and treatment. So I think we can, but the issue again, Dr. Said, is that we have tried in SIN to engage NADRA to help us at least in SIN catch up this data, but it has to come from the top. Because they don't entertain us, so we need to really make this. Yeah, this has to be a policy matter. Only then we can really move forward. Yeah, thank you.
Dr. Huma, thank you very much for your nice talk. Just a little question: do we know that at what stage or what age do we get the maximum infection in hepatitis C? the slide which Dr. Janjua showed, we have maximum prevalence around 40 to 55 years of age. Does that mean that these individuals got infected when they were children? Was it a boom stage of infection, or we get this infection linearly over time? Or is there an age bracket where we are getting maximum new infections?
Yeah, we have this age breakdown, and it very clearly shows that below 18 years, the disease prevalence is about 3 or 4%. Or maybe, like amongst that population, it's very low. But then as they go in 20s, they start getting infected. So 20s, they start infected, and 30s, there's a maximum infection. And another very important thing that has been seen many times is that women before marriage have a very low prevalence of disease. And once they're married, because they undergo surgeries, deliveries, transfusions, they match with males. The male and female infection becomes the same. So it's 20 years, and then they start getting infected. So that was the reason that we thought that for investing into this elimination program, for the first few years, for the first 5 years, we would not screen less than 18 years, because that would be a wastage of resources. But once we eliminate this disease in the adults and adolescents, then we will take up this small population and look after them. Yeah. So like if it's a good thought, and but could really look into it, but the plateau and the way it goes up, it kind of looks as if they were not infected, because that's what happened in Egypt, and they saw those people. So maybe Vakit, you can elaborate more, because it doesn't look like that.
We have the same age-related prevalence of hepatitis C in Egypt. Most of patients who were infected when there was intravenous treatment for schistosomiasis until the late 70s, early 80s. So older age patients, people above the age of 50, we have almost 40% prevalence. Below the age of 20, the prevalence is 1% or less. So when we started the national screening campaign, we started screening above the age of 18. And then during the screening campaign, treatment was approved for teenagers. So we had a program where we screened teenagers in schools, and we found the prevalence very low. But we actually screened 7 million school children, and we only found 20,000 infected. So actually, the proper return on investment would be screening in the infected age group, which is about, in Pakistan, and I think it's above the age of 20, 25.
Last comment from a question from Dr. Said Hamid.
Mike वापस कर दिया था because there's a it's gone quite far. Just Dr. Numan के question answer में, please be aware that CNIC के ऊपर बहुत कुछ नहीं पढ़ सकता. If you start putting in hepatitis C positive and hepatitis C negative, there's a lot of stigma that is still there. और ये भी हमें एक policy पे काम करना है कि अभी भी employers are kicking out their employees अगर hepatitis B cephalosporin positive नजर आ जाए या hepatitis C positive नजर आ जाए. And we be talking not about healthcare workers, we will be talking about cooks and drivers and so on and so forth. Please remember that point, that it is important to be.
Thank you very much, Dr. Said Hamid. So we're going to move on to our next talk. We've heard in this whole, session, as well as yesterday, all the efforts that Egypt has made. Egypt is now kind of one of the only countries in the world that has reached the elimination target, and I think they're going to announce it soon, which is kind of remarkable. We have Dr. Imam Waqid here, and we're going to learn from his experience and hopefully follow his path. He's a professor of medicine of hepatology and a previous chairman of the hepatology and a past dean of the National Liver Institute. He is a board member of the Egyptian National Committee for Control of Viral Hepatitis, which sets national strategies and guidelines and oversees the national hepatitis C treatment and screening program in Egypt. So Dr. Imam, please take this time.
Thank you very much. It's a pleasure to be here, and I first would like to start by thanking Professor Akhtar and Dr. Amara for inviting me and at the PKLI, and thanking them for giving me the chance to visit Lahore. It's my first visit here. It's a beautiful city, and visiting this outstanding, prestigious institute. And I'd like to congratulate them on the setup of the institute, which is world-class facility, and congratulate the people of Pakistan for the launch of the hepatitis program, which I hope and I'm sure will be a great success. In the next few minutes, I'm going to share with you what we did in Egypt and how we reached almost complete elimination of hepatitis C. These are my disclosures. And very briefly, I'll go through the magnitude of the problem of hepatitis C in Egypt, our national treatment program, and then the massive national screening and elimination campaign that was started in 2018, its outcome and impact, and try to summarize some lessons learned and success factors. Until 2016, Egypt had the highest prevalence of hepatitis C in the world. Our national survey in 2015 showed that 7% of the adult population were viremic, which was a number of close to 5.5 million infected people. This put Egypt at as the fourth country with the number of infected people after China, Pakistan, and India, although we have a much, much lower population than these countries. And this is a huge number. This is equal to the number of hepatitis C patients infected in all these 38 countries in Europe, all Western Europe, Central Europe, Eastern Europe, despite our very low and limited economic status. And this translated into a huge disease burden, almost 30,000 mortalities due to hepatitis C complications every year, and a total of 450,000 disability-adjusted life years lost due to direct and indirect costs, and a huge economic burden, almost 2.7 billion in indirect costs and 0.6 billion in direct healthcare costs. This translated in 1 to 1.4% of the GDP lost annually due to hepatitis C. This is as huge as the burden, the total economic burden of cancer in Europe and the burden of cancer in the United States. So hepatitis C was a major health and economic problem in Egypt. And at that time, in 2015, we calculated that if you cure one patient, you will save $10,000 over the following 20 years. And if you prevent one infection, you will save $20,000 over the following 40 years. So treating and curing and preventing hepatitis C is an economic benefit for the country. The National Treatment Program started in 2006 by establishing the National Committee for Control of Viral Hepatitis. It's a committee of volunteer professionals that sets the policies and plans and guidelines for managing hepatitis B and C problem in the country. From 2006 to 2014, the committee established specialized treatment centers that were treating patients with interferon at the time. In 2014, we introduced sofosbuvir from Gilead at a discounted price, at an access price of $900 for a treatment course. And at that time, we prioritized treatment for patients with advanced fibrosis. By 2016, locally manufactured generics were introduced. We had sufficient supply of the medicine to treat all patients. So by 2018, we had treated more than 2 million patients had started treatment. This graph shows the number of patients starting treatment monthly from the introduction of direct acting antivirals in end of 2014 until 2017. Almost all these patients were those living with the diagnosis, patients who knew that they have hepatitis C, came forward for treatment, and these amounted for around 2.4 million patients. The pie chart shows who paid for the treatment. Almost all patients did not pay, only 15% of the patients paid out of pocket. Where's the pointer? It doesn't show. And most patients were treated on the expense of the state. No problem. Okay. Only 15% of the patients treated out of pocket. Most of the patients, or 85%, were treated on the expense of the state or health insurance. At the tail of the graph, you see that the number of patients coming for treatment flattened and became very low. And this was because almost all patients who knew that they had hepatitis C have been treated, and the program started losing momentum. At that time, we estimated that there were at least 2 to 3 million with undiagnosed hepatitis C that needed to be found and treated if we wanted to eliminate the disease. And by 2018, the treatment cost had decreased much. Generic, locally manufactured generic had reached the cost of $80 for a treatment course. So at that time, the government decided, let's find all the patients infected with hepatitis C and treat them and get rid of the disease once and for all. And we decided to screen everybody in the country above the age of 18. It's a target population of 62.5 million. If they had not been previously treated, we excluded the 2.4 million who were treated previously. And at that time, also, when the drug treatment was approved for teenagers, we started screening 12 to 18-year-olds in schools if their parents agreed and signed a consent that the children be screened and treated. This was a national presidential program, and it was supervised by the president himself, and he had daily follow-ups of the whole program during all its course. We changed the screening tests. We had small screening tests before, but they were based on ELISA tests, and this was not very efficient. We started using a point of care test, and we negotiated the price with Abbott down to 56 cents a test. At that time, this was a very cheap cost. That included all the logistics of the supply chain of providing the test to all the test sites. We managed to negotiate the viral load test with Roche to less than $5, $4.8 a test. And we even negotiated the cost of treatment further down to $45 a treatment course. It took 2 to 3 months of planning and training and procurement and negotiations. Abbott trained 300 trainers to train the screening teams, and they initially trained 6,000 healthcare workers to do the screening test. And the country was divided into 3 phases. Each phase over 2 to 3 months contained 7 to 11 states. We have 27 states in Egypt. And each phase had a target population of 18 to 24 million. Each phase had between 4,000 and 6,000 screening sites. Screening sites used to work 12 hours a day, 9 to 9, 7 days a week, 30 days a month, no holidays, for the whole 2 or 3 months of screening. All hospitals, healthcare facilities, primary healthcare units, rural health facilities in the country participated in the screening, including all military health facilities, police health facilities. So all the health system in the country was part of the screening campaign. We used mobile units to augment the screening efforts. These used to go to mosques on Fridays for Friday prayers, to churches, to stadiums during sports events, subway stations, train stations. This was assisted by a huge media campaign. We had billboards all over the country, TV ads, radio ads, personal meetings. Phone companies used to send millions of text messages to their phone subscribers. And we used movie stars, sports stars, religious stars for these campaigns. Patients could walk into any test site in the country. It was not linked to their neighborhood or their residence. They immediately had a test done. The results would come out between 5 and 20 minutes. And they were immediately electronically linked to evaluation and treatment sites. So if a person was tested and he turns positive, he will immediately get an appointment in the neighboring regional hospital for evaluation and RNA test and being evaluated for treatment. And we contracted a national call center to call all patients who don't show up for their appointments. If they're seropositive and they don't come, if they don't come for the treatment, so they know why they did not come and reschedule their appointment. So this was a massive activity. This shows numbers. Altogether, there were 15,000 plus healthcare facilities involved. 58,000 healthcare workers were involved. 5,000, almost 6,000 trainers and training of trainers. 20,000 medical teams. The average screening per day was around 240,000 in 6,000 screening sites. The turnaround time, 20 minutes. We had 77 PCR sites active in each phase of the 3 phases of the program. And the capacity of PCR testing was 36,000 per day. The turnout for the PCR result was between 2 days and 1 week. So the maximum delay for the PCR result was 1 week if there were technical problems in many of the sites. This was the graph I showed you earlier, and this was the flat number of patients starting treatment in the end of 2017. And this was what happened with the start of the program. Above 200,000 patients started treatment in each month of the 7 months of the campaign. So the target was 62 million. Almost 50 million came forward for screening among the adult population, which is 80% of the target. And we found 2.2 million who are seropositive, which is 4.6%, because we excluded those who were previously treated. So this will amount to almost 7.5% seropositive in the country. Among the target teenagers of 12 million, 7 million were screened, and the prevalence or seroprevalence was only 0.3%. And we published this in 2020 in the New England Journal of Medicine. And this table shows each state in the country, the prevalence in each state. So most of the infection is localized in the Nile Delta and the North Nile Valley states, because these are the agriculture states where schistosomiasis was high in the 50s and 60s, and where the population took the anti-schistosomiasis treatment. And this shows each state. The size shows the number of infection, and the y-axis shows the prevalence. This is the highest states. The lowest infection is in the desert states in yellow, and the lowest numbers. So we managed to map every neighborhood in the country. We have data for hepatitis C prevalence in every single neighborhood in the country. And this shows the prevalence in females. The central part of the Nile Delta and North Nile Valley have the highest prevalence in females, and this is the prevalence in males. It's much higher. So during this campaign in 2018-19, we treated in the committee's database 1.6 million patients with a recorded SVR of 98.8%. So everybody who is cured. And since the start of the treatment program in 2014, 4.2 million received treatment in our database in the National Committee. This excludes those who were treated in private practice who are not in the database, with a recorded SVR of 97%. The impact, we have calculated the impact both by modeling and by actual survey. This what would have been the case in Egypt if we had not done the program in 2000, or the screening, national screening program. Sorry. In 2018, we estimated that there were 2.1 million infected people. If without the national screening program, by 2030, these would have been 1.4 million left patients untreated, or 1.2% of the population. With the national program, in 2020, we estimate that there were 500,000 only patients remaining, or 0.5%. A survey this year showed that only 0.28% are viremic in Egypt, and we estimate that by 2030, the prevalence will be 0.18%, or 1.2 million fewer cases than if we had not done the screening program. This will prevent 180,000 new cases between 2018 and 2030. And we have several incidence studies in the center of the Nile Delta. In 2005, in this area, the incidence was 610 per 100,000 person, which meant that at that time, there were 200,000 new infections in the country in 2005. In 2013, in the same area, we still had a high prevalence, which meant that there were 130,000 new infections. The impact of the initial treatment between 2014 and 2018 resulted in decreasing the incidence. And now we estimate that the incidence has gone even lower. And now we have not more than 10,000, or close between 6,000 and 10,000 new cases of hepatitis C in Egypt every year, down from 200,000. This program will save at least 60,000 cases of hepatocellular carcinoma over the next several years until 2030, and will save 80,000 liver-related mortality or hepatitis C-related mortality by 2030. We just published this outcome in Liver International. And this shows that we have achieved all the WHO set targets for hepatitis C elimination. We diagnosed more than 90% or almost 95% of the infected population. We treated more than 90%, close to 96, 97%, cured more than 90%, and will achieve more than 65% reduction in mortality. The economic burden is very important, and it is very important. It was very important for us to show the politicians this is what they look for most. The total cost of this program was 207 million. To identify and cure one viremic adult who was unaware of the diagnosis costed $114, and this would save $10,000 in the next 20 years. And to identify and cure one viremic teenager costed $365. The program will prevent almost 880,000 disability-adjusted life years between 2018 and 2030. And this will not be at an incremental cost. It will be at a saving cost. the program will be cost saving in the next 30 years, and that to save one disability adjusted life year saves $40. It does not cost money, it saves money. And this is the cost, as the total cost between 2016 and 2030. Without the national treatment program, the total direct and indirect care cost would have been 17 billion US dollars. By implementing the program, this will go down to 12 billion, and this program will save $4.7 billion until 2030. And this is the numbers that the politicians love. Each dollar spent in the national screening and treatment program will save $26 by 2030. And screening and treatment campaign will save $20 billion over the next 20 years in both direct and indirect costs. So actually, it's a very good economic investment, and it will say it saves lives, it saves disease, and it saves money. What are the success factors? A few years ago, Homer Al-Zafi and his group published a study on the high-income countries, and they estimated that by 2030, only 9 high-income countries will be able to eliminate hepatitis C. And what was common in these countries are these factors. Most importantly, political will, financing a national financing program to expand treatment beyond specialists, remove treatment restrictions, treat everybody with hepatitis C, awareness and national screening programs, and national linkage to care program. All these were available in Egypt. Unfortunately, we do not have an effective harm reduction program. I don't know if there's an effective harm reduction program in Pakistan or not. And as we can show that elimination is possible even in resource-limited settings, what were the factors of the success in Egypt? First, there was a very important and large society and social pressure to drive policymakers to adopt a national treatment program. Hepatitis C was a huge disease in Egypt. Everybody had a patient in the family or a relative or an acquaintance with hepatitis C or who had died of hepatitis C. And several of our previous presidential candidates and presidents had hepatitis C. So everybody knew of hepatitis C. Secondly, the political will and support. This program was supported by the government totally. The president himself oversaw the program daily until the program completion. And it was a national program. All agencies and civil society were aligned. There was a huge media and ad campaign, which was very, very important. The government allocated sufficient resources initially to start and maintain the program. All the funds were available upfront. The mass procurement through a single negotiating body. This brought the prices down, the prices of the diagnostics on the treatment. The availability of low-cost, simple, rapid diagnostics was important, the affordable therapy, and that all services were free to patients. All patients were treated for free in the program. All diagnostics were free, evaluation, treatment, and follow-up. Even patients who could afford or patients who had private insurance were all treated in the program for free. One of the important things that there was a single empowered body for planning and management, the National Committee for Control of Viral Hepatitis, that was established in 2006. 11 ministers of health change, but the committee was there, and its policies have not changed with any change in the ministers of health. So the guidelines and the directions or the policies that the committee sets are adopted and continue. The management guidelines we made were very simple. This allowed us shifting to non-specialists. The program was overseen by hepatologists and gastroenterologists, but was run by general internists and general practitioners who had quick training for using the diagnostics and for managing hepatitis C and prescribing treatment. The guidelines were very simple, adaptable. We changed the guidelines several times with the availability of new treatments. And we treated all patients regardless of fibrosis stages, and we only used biomarkers to assess fibrosis to assess whether the patients need to come back for follow-ups or not, and immediate and effective linkage to care. Patients used to come for 2, maximum 3 visits to receive treatment, and they received the 3 months of treatment upfront and did not come back except to assess the SVR at month 6. So this was the largest disease screening campaign in the history of medicine until you start your program. Your program will be much larger. We have almost completed eliminating hepatitis C. Over 7 months, we screened 57 million, diagnosed 2.3 million seropositives, and treated 1.6 million viremics. Since we started the treatment with direct-acting antivirals, more than 4.2 million have been treated, mainly with generics and with more than 95% success rate. We were the first country to treat and screen teenage population. We are the first country to eliminate hepatitis C despite the highest burden and our limited resources. And what was achieved in Egypt can be repeated everywhere and definitely can be repeated in Pakistan. And thank you very much for your attention. Thank you.
Thank you very much, Dr. Imam. We're going to do, I'm sure everybody has a lot of questions because this is what we have to replicate. So we're going to do a 5-minute question hour session, but I'm going to take one moment just to say, we're getting 24 or 17, 18, sorry, clinics back. And so we charted, we have 57 million people in those districts where the clinics are. So we have an Egypt within Punjab that we have to screen. So I think this talk was very well, and I hope we can present that at 5-10 years down that we've done that. So we're going to start with Dr. Saeed. He has a comment. If the mic person can give mic to Dr. Saeed, and then we'll start.
Thank you, Dr. Vakid, for number one, taking time to travel and sharing your experience with us. And I'm a big believer that where there's a will, there's a way. We have to create means to do what we think is the right thing. It's not a question of if we should do it. I think it has to be done. So my first question to you is, did I understand you correctly that in your first phase of the treatment, it was SOF alone and nothing else? In 2014 through 2000?
Starting 2014, it was SOF plus. Either we started with SOF plus ribavirin or SOF plus interferon, and then we shifted to SOF plus simiprevir, and then SOF plus daclatasvir.
And then second question is that the patients that you screened, out of the screen positive patients, what was your disease positive patient?
It was 70% of the seropositive. 70% were viremic. Yes.
Thank you, Dr. Imam, for a very interesting talk. My question, because lots of the issues we discussed earlier, you screen almost all of your population. And how did you avoid issues of duplication, retesting, missing links? Were they electronically controlled, linked to a central database? How the system works in your country?
We have a central database for the National Committee of Viral Hepatitis, where everybody who is treated on the expense of the state is registered. In the screening program, we linked all the screening sites to the central database. And we have data for everyone who was screened, his national ID, his sero status, and his later follow-up and treatment. So all this is linked electronically. So if a patient was screened in one site and he goes to another site, his national ID will show in our database that he was previously screened.
And one
Any,
last question
we have,
is, sorry,
okay.
one last quick question is, what was the most important factor in your motivational campaign which led to force people or invite people to come for screening?
I think that the most important thing in Egypt was the national awareness of the hepatitis C problem. Everybody knew that of hepatitis C, and everybody wanted to know whether they have hepatitis C and get treated, and that everything was free was a positive factor. And the media campaign, we had a huge media campaign. We're on the front page of every newspaper in Egypt for the whole 7 months. And when you open the TV, you'll find somebody tell you, go get tested, save your family. So this was a very important message, and that drove almost everybody to come. And when we screened 50 million out of the 60 million, there are 10 million Egyptians who work and live abroad. So we almost screened everybody who was in the country.
We have a question by Dr. Anwar, then followed by Dr. Asad. So Dr. Anwar Khan.
Okay. Like in Egypt, a lot of people from Pakistan, they go and work abroad in the Middle East and anywhere else. And most of these countries, they bar them from entry if they have hepatitis B or C. And also in Pakistan, there are several departments which will not hire them. Do you have similar situation in Egypt, and how did you tackle it?
We have exactly the similar situation. Everybody who wants to go and work in the Gulf, if they have hepatitis B or C, even if they have hepatitis C antibodies, they're not allowed to go and work. And in Egypt, many of the employers, their pre-employment includes hepatitis B and C, and they don't employ them if they are hepatitis C positive. In this program, we issued a certificate of cure for everyone who came for an SVR and was cured. We issued a certificate of cure that can be used for employment, at least in Egypt. It's not yet effective in the Gulf states, but in Egypt, it allows them to be employed.
Thank you. Next question by Dr. Asad Chaudhry.
Thank you. Excellent presentation and momentous work. My question is, what about the linkage of care of those who were virus positive? So what percentage you were really able to link to care? And what did you do about the people who did not turn up for treatment, despite being virus positive in your database?
Okay. Linkage to care was electronic immediately. Everybody who tested positive got an electronic appointment in a regional hospital where he was supposed to go to be evaluated and have a PCR to decide on treatment. If he did not go, the call center, if he missed his appointment, the call center would phone him and see why he did not go. There was a slide that I did not show that what was the outcome of the call center. The call center contacted more than 250,000 persons. Most of them needed rescheduling of the appointment or a change of location. So this was done, and almost 15% were treated in private. So they did not come for treatment. They knew that they were seropositive, so they went to private practice and were treated in private practice. They were all treated.
Question by Dr. Faisal Dar.
Thank you very much. It was a very nice presentation. I myself is a liver transplant surgeon. So my question would be from that side. You have treated such a big number of patients. In your presentation, you alluded to the detection of fibrosis by biochemical markers, although you did not went through the details. What I want to know is how many of these patients who were treated out of your population were cirrhotic or advanced stage of fibrosis? And would you, as a central committee, has recommended HCC surveillance strategy for these patients?
Initially, when we started the program in 2014, before this national screening, we used to treat only those with F3 and F4 fibrosis. So in the initial period, the patients with advanced fibrosis and cirrhosis was skewed to more than 60%. And this screening campaign, it was the opposite. Patients with cirrhosis were 30% or a little less than 30%. We used FIP4 as a biomarker to tell patients that they need to be followed up. And in late 2019, we started a national screening program for hepatocellular carcinoma. It was disrupted with the COVID, but it started again in last year, and now we have almost 100,000 patients who come for ultrasound and alpha-fetoprotein screening for liver cancer. But unfortunately, now we have a huge wave of HCC, and we have close to 30,000 new cases of liver cancer every year.
Just want to take it a little further. So you are doing a national screening for HCC for this particular set of patients who were found F4 on your initial hepatitis C elimination campaign. Okay. Okay. I think this is important to consider if we can successfully launch a hepatitis C elimination program, because a lot of these patients will be cirrhotic. And according to their data, 30% of their patients were cirrhotic. And if we are going to treat 10 million, that means 3 million. And if we just, look at the Egyptians number, so at least we will have 3 million people who are already cirrhotic. So we need to incorporate the HCC surveillance program into this program. I think that will be the way if we are going to save $26 for spending $1.
At least start the hepatitis C screening and elimination campaign. Don't make it a complicated program, and then add things later. But because if you actually start, it will go on and it will never stop. So take the first step, start the screening program and treatment program. It will go on perpetually.
To be part of the bigger plan as a follow-up subsequent screening.
If there are no further questions, we're running short of time. So I understand, but I'm really sorry. In the interest of time, I'm going to move forward. We're running an hour behind and we have some excellent presentations. Our next question, our next speaker is going to be Dr. Anwari Khan. Dr. Anwari Khan is well-known hepatologist. He is the chairman, and he's the ex-chairman and dean of head of gastroenterology, hepatology, Sheikh Zayed Medical Center, Lahore. He was also worked at the University of Punjab and the former chairman for the postgraduate Institute. I would like Dr. Anwari Khan to come. His talk is going to be about HCV reinfection, myth or reality. Thank you.
Thank you, Dr. Mara. Thank you very much, Dr. Faisal Dar, Dr. Usman Ajla, Dr. Saeed Akhtar for inviting me. PKLI has been very close to my heart, and congratulations for doing 1,000 transplants in a very short period of time. Yeah, this is a great achievement. The topic assigned to me was reinfection. Is that a myth or reality? And emphasizing some of the problems we can tackle. WHO's logo was HEP cannot wait, but PKLI has challenged it. We are not waiting. So I think this is a big challenge, and we must move forward with this program by the Prime Minister, which was announced yesterday. That's a very robust program and a great effort. Hepatitis C is a major health problem. As we know, 71 million people and a leading cause of mortality. The DAs have really brought a stop to the HCV, and the cure is now not far, and therefore the WHO motto of stopping or curing hepatitis C by 2030. And Pakistan is one of those countries, as we heard from the figure, is the largest burden of hepatitis C in the world. Is the hepatitis C reinfected? This is a major public issue. I think out of the 5,900 patients who were looked at in this British Columbia Center for Disease Control, they found that 3,690 individuals, they achieved HCVR clearance on their own. And 2,225 individuals achieved SVR after interferon-based treatment. Overall, 452 reinfections were seen with a rate of 1.27%. This is out of a general population. So the reinfection rate, which is recognized after treatment, runs about 0.5 to 1% throughout the world data. What they found was that reinfection rate was much higher in those people who were using drugs, people who were injecting drugs, in HIV, and those who had sexual orientation, which was men with the men. And they were the ones who were having the reinfection rates higher. And they had defined what was reinfection, what is spontaneous clearance, and definition as here. So they found out that out of the ones which were drug injecting, the reinfection rate was 1.14 100% years, and in HIV was 4.17 per 100% year. So the reinfection rate, although was higher, but in the HIV patients, they were much higher. And in other studies, we found that there were very close correlation of 1.21 and 4.9 in HIV persons. The high reinfection rate was also seen by the recent drug users. This was a study in Iceland. They found that 614 patients, 417 were male, and they all resulted in cure. But reinfection rate in 52 patients were confirmed, those who were using drugs. And the median time for reinfection was 232 days. And they had all had history of intravenous drug using, and total of 523 patients, 84% had recent IDU, and then 220 were retreated, and they were like 34.4%. The infection rate in this study was 7.7 per 100% years. And this is another study where they showed that the high risk population had reinfection rate of close to about 10%, and with HIV and HCV, both reinfection rate about 15%. There is a study from Australia where they found that 10,000 plus individuals initiated treatment, 81% achieved SVR, and had no record of any subsequent treatment. Therefore, it was a very high cure rate. And post-treatment viremia was 5% in 526 people. And then they found out that those who were reinfected by the drug use, their retreatment with of the reinfection was also highly effective. Therefore, the reinfected or infected people should be treated as the general population. HCV reinfection on hemodialysis study, which is usually the case, people are getting we have figures like about 50% people who go on hemodialysis will get HCV, and there is a high infection rate. But is there a reinfection after you treat them? This study was done for dialysis patients, and 374 patients with the hemodialysis, 1,071 reference patients who did not have hepatitis C, and they were as a reference. And they found out that the risk of reinfection in these hemodialysis patients was very minimal. It was about 1.39%. So this is the inference of the study, with the maintenance hemodialysis 0.23%, and in reference was 0.16. It was not significant. So if you treat hemodialysis patients, the reinfection rate is very small. So for reinfection, whether it is a single genotype or if it is a viremia with multiple genotype subtypes, you start treatment, and end of treatment SVR in 12 is the same as it is for general population. So reinfected patients should be treated and not ignored. This is a slide from courtesy of PMRC. We know that in Punjab, the high incidence was recorded in the earlier survey, and today we heard it's about 7 million people who are infected, and in Punjab, it's about 9% of those, very large burden. And so how do we contemplate this high burden and reinfection in our population? This is a data which I got with courtesy of Dr. Abid Gauri from Punjab. And there is a cure rate of about, in this population, he is given by years, about 89 to 93% cure rate. But there is a relapse rate. Whether it's a relapse rate or a reinfection rate, we don't know, because really there is no gene sequencing here. We can find out the difference between reinfection or relapse. But at least we know that about 7 to 10% people will either relapse or not respond, or relapse late. Okay, so in hemodialysis, there was one small study by in Jinnah Hospital. They found out that there were 32 patients, and they found that they were treated 3 times a week or daily treatment, and they found that there was no reinfection in group 1, and reinfection was seen in 2 patients with the same genotype, and those who were treated 3 times a week. And there was no significant difference between the 2 studies, between the 2 groups. And they found that the infection is basically from surface and cross-contamination by those who are working in the dialysis units. So dialysis is pretty much safe for reinfection if you treat them. But the initial infection in dialysis needs to be curbed. Internationally, it's about 20% reported from Italy and 50 to 60% in Pakistan. I think we have to work hard on surface contaminations and screening those people who are working in dialysis. This is a group of persons who are injecting drugs, and the WHO estimates are about 3 million population living in Pakistan are injecting drugs. This is a huge figure, which goes underreported in Pakistan. In 1999, UNDCP and UNAIDS program showed that there was a sharp increase from 1986 to 1999, from 1.9 million to 3 million population who are injecting drugs.
178 sampled for persons who were injecting drugs. There were 89% were positive for HCV, 64% with a history of reusing of syringes, and 48.5% responded that they were sexually active. So they are infected and they're transmitting to their partner or whoever. 49% switched from smoking to drug injections. So this is very alarming. And there's a looming threat of persons who have now HIV and have a cross-sectional spread of sex workers to the uninfected individuals in the population. Modes of drug use were smoking in 27%, inhalation in about 2%, and did not answer were 2%, and chasing was like they sniff cocaine through sniffing with a foil. And that, unfortunately, from 69% has now changed to 49% chasing changed to injections. So that is alarming. Level of education in this group was college education was 2%, secondary school education 20%, primary was 10%, and uneducated were 68%. So how do you get to the uneducated people who are using these drugs? That will be a big challenge. And they recommended that there should be like more of a visual information to them than a written information for uneducated people. It has been a big switch from using cocaine as intravenous drug using, because cocaine has become more expensive. It is a drug which is very closely looked at by the government for its trafficking. But these drugs, which are prescription drugs, are easily available from the stores. And now there are some policies which are curtailing the use of these drugs. Temgesic, morphine, Avil, diazepam, marzine, heroin only 2.5%, but mostly morphine and opiates and analgesics. From 12 to 13, drug use survey in Pakistan showed 4,533 drug users. There were 51,000 individuals who were randomly selected, 1,200 informants of drug users, cannabis resin, which is chars, opium conversion to heroin by acetic anhydride, which is done in a lot of underground factories mostly coming from Afghanistan. Medicinal use, abuse of drug, which is common. 9% of the adult male and 2.9% of the adult female, equivalent to 6.7 million, had used a substance other than alcohol and tobacco in the preceding year. In 2023, ice crystal methamphetamine is used on the rise, as we see in our news media. Unfortunately, it's happening in the universities and colleges. The new survey has started from 2022 to 2024. That will give us more information. How do you differentiate between reinfection and relapses? The new generation sequencing and sequencing through a technology of the cellular molecular biology, the distinction between HCV RNA, late relapse, and reinfection is possible. We do need to, in this specific group, use next generation sequencing to determine whether they're getting reinfected or they're getting multiple genotypes. And that you can determine by this methodology. Hepatitis C in this study by Idris Khan, very good study, and Saibzada, was published in, I think, 2022. The drug users residing in the provinces were tested for molecular markers of HCV infection. NGS was used, and with a hypervariable HVR and a global hepatitis outbreak and surveillance, which is GHOST technology. And they found out that there was multiple genotypes and in those people who were injecting drugs. And these genotypes were 1B, 3A, 1A, and 4A were detected in those people who were reinfected by sharing needles. HCV reinfection, is it a myth or reality? It's a reality, mostly in the people who are injecting drugs. The pool is hard to break because, first of all, they are ignored. Number two, they are very poor and they have no resources. And there are only 48 drug control programs who can bring them out of this pool and rehabilitate them within population. And that's much less than desired. There are no safe injection programs. Safe injection programs are harm reduction programs all over the world, where you tackle these people, give them new syringes, and they're not going to give up their habit right away. You have to bring them in the program, give them the clean new syringes until you rehabilitate them, counsel them, rehabilitate them back in the society. And until that is done, and we keep ignoring this segment of our society, we will never get out of this. And especially with the HIV on the rise, they can infect the normal population with this very complicated genotypes. There's no effective rehab program socially, financially exist for this population. What are the preventive strategies? Screening undetected person, test and treat. Identify high-risk individuals. Men are high risk, younger age is high risk, and syringe sharing is common in colleges and universities where these drugs are being used. Needle and syringe prevention program, psychiatric care to prevent risky behavior. There are a lot of people who need psychiatric care because their behavior is risky because they are born that way or they have the circumstances of that which bring them to this level, and they need to be brought out and treated in the psychiatric centers. Harm reduction to prevent unprescribed access to drugs. Implementation of the Control of Narcotic Substance Act, which is 1997, which prevents you from prescribing dangerous drugs or narcotics. And there is very little implementation. You can buy anything anywhere in smaller towns and stores. Screening of blood and the blood products. Limit unnecessary use of syringes. We have heard 7 injections per year. This is unacceptable, and these are not injections which are needed. Self-destruct, one-time use of syringe. Proper sterilization of medical, surgical, dental instruments. Disposable, one-time use of accessories, which are commonly used in cardiology, gastroenterology. They must be used only once and discarded. And proper disposal system that needs to be implemented. Barbers, circumcision, ear piercing, operators, they should be registered and educated with compliance. Thank you very much for your kind listening.
I'm going to ask Dr. Marikha to be seated, and then we're going to take question session. So any questions? And this question session is going to be between you and T-Brick. So Dr. Asad.
Thank you very much, Dr. Anwar. This has been a challenge. We are struggling to get people for SVR12 when for reinfection means we're going to check the PCR, sometimes down the road or sometimes the patient who presents. Just to share an information that one of the studies that we have been involved in, we managed to get 41 patients who achieved SVR12 1 year after the SVR12 PCR, and we only had one person who was positive, virus positive. So we'll be looking with this. Some more data will be coming up, inshallah. I think it's a 5-year project with Professor Graham Foster. So So we'll have some idea of what the reinfection is like in Pakistan. But getting SVR 12 here is a challenge. It will be a bigger challenge. I would love to hear the Egypt experience here.
Dr. S, you checked these 40 patients. Were these patients belonging to high-risk group or these were just random patients?
Part of a study that we are doing with this is hepatitis elimination in Pakistan with Graham Foster. And it's just a part of the protocol. We have to call them back in. It's all, they're not specifically high risk groups.
In Egypt, we don't see a high rate of reinfection in patients who were treated with direct acting antivirals. We had a study initially before the national screening program, 1,000 patients in Cairo University, and they retested them 5 years later, and they only found one case of reinfection. These were general population, not drug users. And I don't think that there is a high rate of reinfection in the general population when we treat them. And IV drug users have to be retested continuously every month.
Thank you.
Any further questions? I see no hands. So what we're going to do is in the agenda, you see another session, but because we're running behind, we're going to give everybody a break. We're going to break for 15 minutes. Tea is being served on the 3rd floor for invited guests and outside and for the participants. So let's break for tea and please be back in exactly 15 minutes. We have a full packed agenda after this as well. So thank you very much.
कनेक्ट हो गया अब उसे फोन लगाना से क्या ऑडियो कनेक्ट अभी वो मैं उनको जाने का ये हमें वो देख रहे हैं हम तो नजर नहीं आ रहे Hello, Tariq Saab, can you hear us? Tariq Saab.
Hello, testing, mic testing.
Hello, Tariq Saab, क्या आप हमें सुन सकते हैं? तारिक साहब, आपको हमारी आवाज आ रही है?
जी तारिक साहब, आवाज आ रही है हमारी?
तारिक साहब, आपको हमारी आवाज आ रही है?
नदीम, हेलो।
जी
तारिक साहब, आवाज आ रही है? नदीम,
आपको हमारी आवाज आ रही है?
जी आ रही है।
यहाँ पे आवाज रिपीट तो नहीं हो रही?
हेलो, नहीं आपकी आवाज नहीं आ रही है। हमारी आवाज आ रही है आपको? जी जी जी। नदीम, आपको भी हमारी आवाज आ रही?
जी हाँ, हमें आपकी आवाज नहीं आ रही।
आपकी आवाज नहीं आ रही है। हमारी वॉइस नहीं जा रही उनको। हमारी वॉइस नहीं जा रही। ये माइक ओपन करिए। हेलो।
हेलो
जी जी।
आपको हमारी आवाज आ रही है?
ندیم اپنا اسپیکر کا والیوم زیادہ کریں. ندیم اپنے اسپیکر کا والیوم زیادہ کریں.
ہلو
جی آواز آ رہی ہے؟ ہیلو
آ رہی آپ کی آواز آ رہی ہے ہماری آپ کو آواز آ رہی ہے؟
نہیں آپ کی آواز نہیں آ رہی ہے مجھے.
جی آواز آ رہی ہے؟
جی آ رہی ہے ندیم.
آ رہی ہے. ٹھیک ہے آپ کی آواز بھی ہمیں آ رہی ہے.
کہاں آ رہی ہے؟
تو یہی بس پوچھ رہے ہیں والیوم تیز کریں نا اپنا.
ادھر سے
اس کو بند کرو وہاں سے.
بند کر دوں گا.
ندیم اب وہاں پہ ہماری آواز ریپیٹ تو نہیں ہو رہی؟ پھر کے لیے
طارق صاحب آواز ہماری صحیح آ رہی ہے نا آپ کے پاس؟
یار تو یہاں سے بولنا وہاں سے دیکھتے ہیں.
ہیلو مائکروفون ٹیسٹنگ. ہیلو ہیلو.
جی امتیاز آواز آ رہی ہے؟ ہیلو
ندیم اپنا اسپیکر میں بات کریں ذرا زوم پر.
ہاں آواز آ رہی ہے میں نے کہا آپ کو آواز آ رہی ہے نا میری؟ ہیلو ہیلو
ندیم ہماری آواز آپ کو صحیح آ رہی ہے؟
یار اسپیکر کی آواز آ جاتی ہے اس میں. آواز آ رہی ہے آپ کی؟ آواز آ رہی ہے
آپ
میری؟
اپنے مائکرو فون کے لیپ ٹاپ کا جو مائکرو فون ہے نا اس کی ذرا قریب ہو کے بات کریں. میں بھی آپ کے لیپ ٹاپ کا جو مائکرو فون ہے نا وہ صحیح اچھی وائس کیپچر نہیں کر رہا.
صحیح آ رہی ہے آواز آ رہی ہے مجھے وائس.
ٹھیک ہے.
آپ کی وائس مجھے
یہ
آ رہی ہے.
کانسیپٹ کلیئر ہے نا کہ آپ کی اور ہماری آواز آ جا رہی ہے. کم اور زیادہ کو ہم سیٹ کر لیتے ہیں.